Hi, I'm Debbie Dillon, and we're here today to talk about physiological adaptation. Within the unit on physiological adaptation, we're going to be looking at medical emergencies. Underneath medical emergencies, there's 4 key areas that are frequently tested. These areas include the Heimlich maneuver, CPR, tracheostomy care, and care of a patient on a ventilator. Let's begin by looking at issues centering around the assessment of an upper airway obstruction. One of the first things that we would notice is a person unable to speak. Classically, they're grasping their throat, and they will appear to be in respiratory distress. If we do not intervene quickly, the patient will also begin to appear cyanotic or blue. If we again continue to not intervene or assist this patient in being able to breathe, death will occur in 4 to 5 minutes. Now let's look at some of the things that we can do to try and prevent this 4 to 5 minute death from occurring. Now, how do we implement some actions to open up this airway? One of the classic things taught during CPR classes is the Heimlich maneuver. When we carry out the Heimlich maneuver, we grasp the victim from around the back, around the waist, thumb side and fist towards the abdomen, and we perform an inward and upward thrust, forcing increase in interthoracic pressure and allowing the piece of particle of food or whatever they're choking on to be able to be expectorated out of the mouth. We continue to do this until the airway is open or the patient becomes unconscious. If in fact the patient does become unconscious, we could then lay them on the floor and perform an abdominal thrust by straddling their body and doing it from on top of their body. Again, you would continue to perform the abdominal thrust until the airway opens. Of course, you do have to check intermittently to find out whether or not that airway has opened. Now, the second thing that may happen during a code, especially in an acute care setting, is that the airway is not occluded, but the patient is not breathing for one reason or another. Intubation at this point would be indicated. And when we intubate, we can do that in 2 ways. We can use an endotracheal tube, which is a long tube that enters the mouth and goes down into the trachea, or we can put in a tracheostomy. The endotracheal tube is a quicker way to intervene in an emergency situation, but the tracheostomy is also very good for someone with chronic throat or lung disorders. Now, we happen to have a tracheostomy with us, and so I will show you what that looks like. The tracheostomy would be sitting in my throat with the balloon in blocking the airway. This balloon becomes very important because it's what separates the upper and lower airways. Without this balloon, as we try to ventilate through this opening, the air would just rush out around the tube. The balloon blocks secretions also from entering into the lung area itself from the mouth. So it performs 2 measures. It separates the upper and lower airways so that air is trapped in the lung. It also will help with preventing secretions from getting down into the lung that don't belong there. All right, now we will discuss more about tracheostomy care, intubation, and when this cuff is inflated and deflated when we do reduction of risks. The third thing that we can intervene with, we talked about, was the tracheostomy. And again, this is the shorter tube. What's important to remember, whether we have done an intubation with an endotracheal tube or with the tracheostomy, is that we must assess the lung sounds. It frequently occurs during intubation that the tube goes into the right bronchus, and that way the left area or the left lung field is not being ventilated. So we need to be listening to both the upper, middle, and lower areas of these lungs. Now, of course, we don't have a middle lobe on our left side, but we do have a middle lung area. The fourth area that we're going to look at in this section is mechanical ventilation. Once the patient is intubated or a tracheostomy is performed, frequently they are unconscious and they are unable to breathe on their own. So we then will put them on a ventilator in order to try and help assist with breathing. Some of the important things to remember with a ventilator is that there are settings that must be looked at frequently. So let's look at some of the care associated with the ventilator. The first and most important piece of information is to listen to breath sounds. You will hear me say this frequently throughout today. We're dealing with trauma patients, and remember, air and oxygen are paramount to our success in re-establishing ventilation as well as circulation. The second thing we're going to look at on this ventilator patient is to assess the need for suctioning. If we expect the air to be delivered or oxygen to be delivered to the lung through this ventilator, it's important to keep the airway open. Mucus, secretions, fluids block the ability of the alveoli to pick up the oxygen delivered by the ventilator. By suctioning, we remove these loose secretions and allow better oxygenation to take place. The third piece we're going to look at is the need to provide good oral hygiene. If, in fact, the patient has the endotracheal tube in their mouth, it is important to move that tube from the right to the left side of the mouth every 24 hours. This prevents the edges of the mouth from breaking down and ulcers to form. It also helps with positioning and prevents us from chewing the tongue and getting mouth sores. The fourth area we're going to look at in care of the ventilator patient is looking at the patient before equipment. Frequently, as a novice nurse, when the alarms go off on a ventilator, we rush into the room and attempt to shut off the alarm without looking to see if the patient is okay. Remember that the patient takes precedence over the machine, and it's important that we always make sure that the patient is breathing effectively before we adjust any settings on the machine itself. This brings us to checking the settings and alarms on the ventilator. Alarms should never be turned off on a ventilator. They are set to let us know when something is not working properly. Some of the settings that we would look at on the ventilator are tidal volume, which tells us how much is being delivered to the lung with each ventilation, respiratory rate, which gives us some idea what the ventilator itself is set at. It may be assisting the patient to meet that number or may be taking over for the patient to meet that number of respirations. Third setting would be the oxygen concentration. And remember, by looking at the babies who develop oxygen intoxication, that we always want to use the least amount of oxygen percentage necessary to achieve the maximum level in the arterial blood gas of oxygenation of the blood. Some of the other settings that we might look at would be the size setting. And remember, this is what we do when we take a nice deep breath and let it out. And on a ventilator, it does this 1 to 3 times every minute. Now, as I'm up here taping, I'm probably sighing more often than that. Use of energy expenditure would sometimes increase the need to increase the number of sighs per minute. PEEP is another mechanism that can be put on a ventilator, and PEEP stands for positive end expiratory pressure. And what this does is allows the patient who has significant lung disorders to keep the alveoli open as we exhale. Normally, as we exhale, alveoli collapse. But in patients that do not have good lung recoil, when they get ready to inhale the next time, they have already collapsed and they don't reinflate. PEEP allows some positive pressure to remain in those alveoli, so the next time the ventilation comes in, we can in turn breathe effectively. Draining the condensation tubing would be another important thing that we look at when setting the settings and checking alarms. Air cannot get through tubing that is congested with water. It is what gives it that bloop, bloop, bloop sound that becomes very annoying. The next area we will look at under care of the ventilator patient is alternative methods of communication. This patient, especially when the cuff is inflated, cannot communicate with us the way we would normally talk. It paralyzes, if you want to say so, the vocal cords of the throat. So what we would like to do here is give them paper and pencil, teach them hand gestures, pointing boards that they can use, because remember, we need to get subjective information from them in order to evaluate them effectively. The last area we will discuss, of course, is documentation. It's always one of the paramount things that we do in the care of the patient, and in this case, we must document settings, the patient's respiratory effort and ability, as well as their response to the intervention that we're performing. Suctioning, how often we're doing it, what we're seeing, is it necessary every 2 hours, or have we been able to extend that? Now, as we move out of the area of making sure that they can breathe effectively, we move into the next area of assessment of the cardiopulmonary arrest patient. When we look at cardiopulmonary arrest, there are 3 components that must be present. The first component is breathlessness, the second one is pulselessness, and the third is unconsciousness. In order to perform CPR, the patient cannot be breathing. When we check their carotid in the adult or brachial artery in a child or infant, they cannot have a pulse present, and they should be unconscious. Occasionally we will see that unusual individual who continues to stare at us and appears to be awake, but in fact they are not. When we are not oxygenating and beating, we cannot be conscious. At this point we must intervene, or again death will occur, brain death, in 4 to 6 minutes. Now, what are the components of CPR? If you happen to be an international nurse, it's very important for you to attend either an American Heart or American Red Cross course and learn the details of CPR. In order to work in a hospital, we must be certified in CPR. Now, what do we do when we start CPR? The first thing we learn to do is to shake and shout. This doesn't mean to slap them across the face or beat them across the feet. We shake them vigorously, shout their name or shout a name to try and see if we can get them to respond. The worst intervention we could do is to take a person who is sleeping soundly and continue to open their airway and start with chest compressions. You're liable to get a fist in the face, so we need to determine that they are unresponsive. The next thing that we want to do is summon for help. This takes on 2 parts. Summoning for help in an adult means activating the EMS system or dialing 911. This is because we need to get intervention there quickly. In a child, we will actually call for help, not activate 911 until after we complete a full minute of resuscitation. Once we determine that they are unresponsive and we have called for help, we are going to open the airway. Remember, it does us no good to perform chest compressions to circulate the blood that we have not oxygenated. So we are going to open the airway by attempting to breathe into the mouth, and we are going to look, listen, and feel for signs of breathing. The nasal area must be pinched, and we're going to give 2 full breaths. In an infant, we would actually cover the nose and mouth with our mouth. Adults, once we start to do respirations, will receive 12 breaths per minute. An infant will receive 20 breaths per minute. If the airway is occluded, you know now that you would go back and perform some type of abdominal thrusts, or in an infant, back blows and chest thrusts to open the airway. We cannot ventilate if the airway is occluded. We cannot do chest compressions if we cannot get oxygen to the lung. As we continue in CPR, we start to look for whether or not pulselessness is present. In the adult, we will check the carotid pulse, and in the infant, we will check the brachial pulse. Once we start to do chest compressions, we will use 2 hands on an adult, heel over heel, and we will compress downwards on the chest with straight arms using our full body weight. I am capable at my size of performing chest compressions on a 300 or 350 pound man and effectively get a pulse to appear in the neck. It comes to technique, not to size, and children can actually be effective in doing chest compressions on an adult. When we begin to look at how we would do infant compressions, this is where we use 2 to 3 fingers, again the padding of your fingers, and we're going to position them in the mid-sternal area, and we're going to press downwards. Now, we don't want to compress the sternum as much as an infant as we would an adult. In an adult, we are going to compress the sternum somewhere between 1.5 to 2 inches. In an infant, we're looking at 1/2 to 1 inch. A child falls in between. When we are doing a child compression, we usually use 1 hand, and we use the palm of our hand. As we look at how many compressions to ventilations, when we're looking at an adult, we're going to give them chest compressions 80 to 100 times per minute, and in the infant, at least 100 times a minute. Again, the child falls in the middle. All right, let's look at the compression to ventilation ratio. When we're doing 1 rescue or CPR, now this can be with an infant, a child, or in the field where we do not have another licensed medical personnel with us, we would be doing 1 rescue or CPR. This entails 15 compressions to 2 ventilations, and this allows us to get through more cycles frequently without having to change position from the side of the body to the head to ventilate. If we are in a situation where we have 2 medically trained individuals either in the field or in an acute care or long-term care facility or healthcare agency, we can at that point go to 5 compressions to 1 ventilation. Remember that after that 5th compression there is a pause to allow the air to remain in the lung, oxygen to be delivered before we force it back out with that next compression. Now, how many compressions should we be doing? Adults should be receiving 4 complete cycles, and an infant 20 complete cycles before we stop to reassess. At that point, we are going to reassess both pulse and breathing and would activate 911 at this point if we have not already done so. We also, at this point, if we find that we have restored pulse or circulation, we can then intervene with only doing rescue breathing for the adult for 12 per minute, with a child for 15, and an infant for 20. So when we're looking at this, we would continue to provide rescue breathing as long as the individual was having any difficulty with their breathing. This includes someone with a drug overdose whose respiratory effort is not enough to promote life. If their respiratory rate is 4 or 5 or 6, we in turn have to support ventilations, and we would continue to do rescue breathing. Now, when do we stop CPR? We can stop CPR, obviously, when the victim responds. That's the best mode. They wake up, thank us, and go on with their life, hopefully make some changes. Someone takes over for us in that we start to become fatigued. Someone responds, like 911 or another department, and the victim is then transferred, or the rescuer is unable to continue. This creates an ethical issue. We feel terrible when we have to respond by not being able to continue to perform the CPR, but in fact, once we are exhausted, the patient probably would not respond anyway. The next area we're going to look at is an issue of airway obstruction that can occur as acute emergencies, and this would be croup. And we know that croup occurs in small children, and these small children present with symptoms such as a bark-like cough, dyspnea, and remember dyspnea is shortness of breath, cyanosis, or bluish discoloration. Remember, in children, their lips may turn blue, and it doesn't mean that they're necessarily cyanotic. We want to look at the inside membranes of the mouth, the buccal cavity, and inspiratory stridor. Now, any of us that have ever taken care of a child with this viral infection, be it acute epiglottitis, acute laryngitis, or bronchitis, we have seen these children present with this barky kind of a cough or croupy sound. You can hear that the airway is occluded going in and out of the lungs. So what do we tell the mom or the dad to do? The first thing we're going to have mom or dad do is to take this child into a hot, steamy shower area. Now, we're not going to burn the baby, but we're going to take them into the bathroom area with hot steam running. This frequently will help relieve the respiratory congestion that the child is experiencing. It has been found, too, though, that if this is not effective and the mom and dad decide that they're going to transfer the baby to the emergency room or to the doctor's office, the sudden exposure to cool air outside can often get the croup symptoms to resolve. In prevention, children who have developed croup in the past are usually advised to sleep in a cool, humidified area to sleep during time periods when croup is most prevalent. Now, what if the child does not respond well? What if the child continues to show respiratory depression, hypoxia, a decrease in level of consciousness, or their temperature rises above 102 degrees? At this point, the child needs to be transferred to an acute care setting for evaluation. And once they arrive there, they will be placed in a room in the hospital where we will have a tracheostomy set at the bedside. If this child was to develop an occluded airway, we would need to perform an emergency tracheostomy. There is too much swelling in the back of the throat and mouth area in order to use an endotracheal tube. So they would cut into the trachea through the throat and put in the tracheostomy. The croupette or mist tent is used to keep the child in a warm, or actually a moist area. Now, something to remember in the croup tent is that the child here's clothing needs to be changed frequently. This is a moist area. We don't want the child to get sick on top of it by wearing clothing that is wet. Oxygenation is delivered with humidification into the croupette, and IV fluids are initiated. Now, we know it's cruel frequently to start IVs on small children, but remember, hydration is a paramount tool used in the correction of any kind of infection, especially viruses. And remember that children dehydrate very quickly. Antipyretics would be used to bring down the temperature, Tylenol being the drug of choice, remembering that we do not use aspirin in small children because of Rye syndrome. The child's going to be propped on a pillow or put in an infant seat. Again, this drops the diaphragm and allows for an ease in respiratory effort. And One of the most important vital signs we'll be monitoring while the child is in the hospital setting will be its heart rate. An increased heart rate is one of the first indications of hypoxia. Now we've completed some of the issues surrounding problems with respiration, and we're going to move into issues around a myocardial infarction. Again, we're looking at acute emergency situations that need quick response. In this, you will need to know the differentiation between MI and angina, and the medications used such as streptokinase, beta blockers, or morphine. So as we preview this area, we're going to set up for you how to differentiate myocardial infarction from angina, and we will cover the drugs streptokinase, TPA, beta blockers, morphine, dysrhythmics, or those that convert an abnormal rhythm, and anticoagulants. Let's begin by looking at how do we assess the myocardial infarction patient. The difference between angina and an MI is that the chest pain that the patient is experiencing is crushing, it is prolonged, and it radiates to the arms, jaw, and neck. The patient frequently becomes short of breath. They will develop indigestion or some form of gastric discomfort, apprehension, mostly because they have a fear of dying, may develop a low-grade fever, because remember here, with a myocardial infarction, there is infection, there is an insult here, there is injury that has necrotic type tissue. Whenever we have necrotic tissue forming, we have leukocytes. When leukocytes respond to an area, the temperature increases. Here we're going to look at lab values. If the patient is in the acute care setting, we are going to be looking at the white blood count, which increases 2 days to 1 week following the incident, the SED rate, which will be increased throughout the entire time of the infarction and in the post period, because sedimentation rate is looking at inflammatory process. CPK, remember here we're going to look at the MB bands, the myocardial bands, and they are the most important piece to look at initially because they elevate first. They will increase in the first 12 to 24 hours. LDH will respond at a later time, 48 to 72 hours, and will remain elevated for 5 to 7 days, and the SGOT, which increases also at a later time. Now, this is a patient who has taken angina, has taken the 3 tablets 5 minutes apart, their chest pain has not been relieved, and has showed up in the emergency room. We've put oxygen on them, we're attempting to control their pain, but what do we need to do to try and help limit the amount of injury that the heart is going to take on? What actions do we implement for this patient experiencing an MI? One of the first things and most important things to start now is thrombolytic therapy. This must be begun in the emergency room within 6 hours of the onset of chest pain. What thrombolytics like streptokinase or TPA do is dissolve the clot. They help the area to reperfuse. And there's criteria that's used to determine who qualifies for streptokinase or TPA or thrombolytic therapy. They cannot have a history of active bleeding, hypertension, and some other disorders. So there is screening criteria used to determine whether this implementation can be used or not. We are going to throw them on a stretcher and put them on mandatory bed rest. This is to decrease their pain, decrease their anxiety, even though they're in an emergency room with severe anxiety, and hopefully decrease the workload of the heart. We're going to also implement the use of some medications. Beta blockers may be used like Inderal or propranolol to decrease the heart rate or decrease its irritability. Morphine sulfate is used, as we discussed previously, to look at preload and afterload reductions. We want to decrease the work of the heart and decrease its potential congestion. Dysrhythmics that may be used, in addition, before I move from morphine sulfate would also help with anxiety, the shortness of breath, and the chest pain that the patient is experiencing. And this would be given IV, not IM, or by mouth, because we want it to work immediately. Now let's talk a minute about dysrhythmics. Some of the dysrhythmics that are used in emergency situations. Some of the ones frequently seen in emergency rooms are drugs like lidocaine for when we have too much ectopy or PVCs, verapamil, which should be used for too fast of a rate, or atropine for a rate that would be too slow. All these medications will be discussed when we do the pharmacology tape. Anticoagulants would also be started at this time, and this would be your Coumadin and heparin, and this is to prevent any further aggregation or development of clots and stenosis. We're going to monitor vital signs and intake and output, and again, normally we would infuse about 3,000 cc's of fluids into a patient for healthy hydration. In this patient, we do not want to overhydrate, so we will back that to about 2,000 cc's a day or 2 liters, monitor their output, and make sure that they're not developing congestive heart failure in response to the insult. Teaching is the other area that we will work on in the implementation for a patient with an MI. We are going to discuss issues like smoking cessation, reduced stress, decreasing caffeine, dietary changes, in particular fats and cholesterol and calories, and a regular physical activity program at this point, which would be monitored in something like a cardiac rehab program. Healing usually takes up to 6 weeks, so this patient needs to be monitored and encouraged to take things slowly. They do not want to jump into something, and remember, denial is a big piece of information to be working with a patient on that has an MI. Now let's look at some of the rhythm disturbances that a patient may develop that has problems with cardiac functioning. What you will need to know in looking at rhythm disturbances is what is a normal EKG? What's the difference between defibrillation, which is used in an emergency situation, and cardioversion, which is an elective procedure? Also, what medications, such as antiarrhythmics, are used to treat problems with rhythm disturbances? How do we assess rhythm disturbances? The first thing we are going to determine is whether or not the patient has syncope or dizziness. Frequently, when a patient has ectopic beats or a slow heart rate, they develop dizziness. There's not enough oxygen circulating, and their cardiac output has been compromised. So they become weak and they can fall over. Chest pain is another complaint that frequently is discussed when we're looking at a rhythm problem. If the heart is not receiving enough oxygenated blood, it develops pain, just like a leg muscle would. PVCs or a slow heart rate can give a patient too little oxygen and they will develop chest pain. Palpitations and abnormal heart sounds can work together hand in hand. Palpitations are a premature beat or an extra beat, and abnormal heart sounds are our murmurs. Murmurs develop when blood is turbulently flowing through the heart, and we end up with backflow into a chamber or resistance in trying to exit the heart, as in aortic stenosis. Now, in addition to these heart problems, they usually develop respiratory difficulty as well, dyspnea, shortness of breath, and this is because their body feels it needs more circulating oxygen, so it drives them to breathe quicker. Abnormal pulse rates are another sign of a rhythm disturbance, and this can be an increased or decreased or irregular rhythm. Now, as we start to look at each one of these, it's going to be very important to identify which of the rhythms are dangerous and which ones that are life-sustaining. Sinus dysrhythmias are rhythms that arise out of the atrium and are usually not life-threatening. Tachycardia is when the heart rate is greater than 100 beats per minute. Such causes of tachycardia can be exercise, pain, hyperthyroidism, heat, hemorrhage, fever from infection, and what we're going to do is intervene with a drug such as verapamil or digoxin. Now, when we're looking at the reverse scenario, we look at bradycardia, and this is where the heart rate is less than 60 beats per minute. Some of the causes for bradycardia are drug-induced. It could be the Valsalva, which we use in bearing down to defecate, or sometimes even when sneezing. Hypothermia, and remember this is important when we're looking at drowning victims or somebody that has been left outside for a period of time. They go into a lower mode and can be resuscitated. And a potassium that is too high, which eventually can result in asystole. That would not be a good outcome. That would cause death. As we look at some of the other atrial arrhythmias, the first one that we're going to look at is premature atrial contractions. Premature atrial contractions arise out of emotions, fatigue, caffeine intake, or tobacco. And this is where we will feel our heart kind of racing a little bit, but only intermittently, not over a prolonged period of time, which is what differentiates it from paroxysmal atrial tachycardia. These are sustained bursts of a rapid rhythm at a rate of 160 to 250 beats per minute. Now you can imagine that the patient is going to get some dizziness or syncope. We have significantly decreased both the cardiac output and the stroke volume. Atrial flutter is another type of cardiac irregularity that originates out of the atrium. Fluttering occurs where the P waves, which we will discuss later, occur at a rate of 250 to 400 times prior to within a minute period of time. In other words, instead of having one P in front of our large QRS complex, we have multitudes of P waves at a regular interval before each QRS complex. The difference between atrial flutter and atrial fibrillation is that with atrial fibrillation, the P waves are no longer regularly irregular. We don't have the same interval, we don't have the same number of them. So the QRS complexes come in quickly and can wait a long period of time before clicking back in. Atrial fibrillation has a very irregular heart rate. Syncope is always a symptom. They usually develop hypotension, and some of the causes could be COPD, or chronic obstructive pulmonary disease, heart failure, and rheumatic heart disease. Now we're going to go on and look at some of the arrhythmias that are ventricular in origin. Ventricularly originated ectopy can be life-threatening. These are one of the first ones we will look at is premature ventricular contraction. This is what we get from too much coffee. This is where we feel that the horse is in our chest, or we get the extra kick there. And if we were feeling the patient's pulse at the time that they developed a PVC, we would not feel any circulation perfuse. Premature ventricular or ventricular beats do not perfuse because they retrally convert. They start from the lower portion of the heart and project upward instead of from the atrium with a kick downward. There is no blood perfusing. This does alter cardiac output. Ventricular tachycardia is where we have 3 or more PVCs in a row. Standards of care will determine what intervention is indicated based on the number of PVCs and or the ventricular tachycardia and the symptoms that the patient is presenting with. Antiarrhythmics and or defibrillation could be indicated in this situation. Ventricular tachycardia that becomes sustained goes into ventricular fibrillation. And this is what we've seen on emergency shows where they rush in with the shocking paddles to shock the patient. This is a sawtooth appearance to it. Defibrillation is always indicated because at this point in time, the heart conduction is out of sync. We need to defibrillate, put it back to isoelectric, and then let it kind of restart on its own, similar to jump-starting a car. Now, as we look at a couple other ventricular irregularities, we get into an area called bundle branch blocks. Bundle branch blocks are when the conduction through the heart is slowed, as if a bridge is down and the Pony Express can't get over it. So what we attempt to do is develop an alternate pathway in order to get the signal from the atrium to the ventricle. These QRS complexes, and remember that's the big complex, starts to take on the appearance of rabbit ears, 2 little pokes up at the top instead of one smooth cycle, or a W. In other words, the lower section of the QRS complex becomes notched. Another type of conduction problem is the first-degree heart block. A first-degree heart block is determined when the PR interval, and remember the P wave is what initiates the atrial contraction, is when the PR interval becomes long. So we have the atrium saying it's time to pump, we have a little pause as the signal gets down there, but the QRS complex doesn't kick in or the ventricle doesn't kick in when it should. This is first-degree block. If this is left unattended or over time, they can develop what's called second-degree block. First and second-degree block can also be drug-induced, but when we're looking at these, it's the degree of delay between the atrial signal and the ventricular response. As we get into an area looking at the types of heart blocks untreated, these can develop into complete heart block. Complete heart block is when the atrium and the ventricle do not communicate. This is like a divorce setting up. The atrium gives out a signal, the ventricle doesn't conduct, so the atrium does its thing, the ventricle does its thing, and we end up with a heart rate somewhere around 20 to 40 beats per minute. These are patients that pass out with exertion, fall down a flight of stairs, and are found blacked out. Pacemakers are indicated in this situation, and we will talk about pacemakers a little bit later. Now let's look at a couple more diagnostic tools that we can use to try and evaluate the status of the heart. Here we've been talking about some of the patterns that we would see, and ABGs can lead us into some of these. When the oxygen saturation of the blood, or the PO2, drops, we end up with a heart that is unoxygenated, and ectopy develops. So when we're looking at diagnostic testing, it's important to find out whether the heart problem has a lung originality. In other words, is there a lung problem that's driving the cardiac symptoms? If in fact we're not sure, we can put the person on a Holter monitor. A Holter monitor uses an EKG printout with a diary in order to allow the patient to document fluttering sensations, activities, when they eat, when they sleep, and it's a diary of what has gone on during the day. What they are going to do now is go back and look at this 24-hour record of the heart tracing and correlate it to what they have indicated as activity in their diary. Cardiac catheterization is another diagnostic tool. This is an invasive procedure. It requires the use of a permit. It does have some hazards associated with it, and it can also be used as an intervention. This is where we go in and run a central line in through the groin or the arm up into the heart itself. It gets fed out to the coronary arteries and dye is injected. We get a picture as the dye spreads through the coronary arteries, and this allows them to evaluate where there would be a blockage. If in fact they could reach the blockage, they can inflate a balloon, and that's called PTCA, which we will talk about again later. Echocardiograms are another type of diagnostic test. Echocardiograms work very similar to the sonar that's in a submarine, and what it picks up are the sound waves that are being conducted through the heart in order to monitor how the flow is through the chambers. Patients that have valvular problems will show backflow as they go from one chamber to the other. You will see not a clean flow, and you'll see swishing of blood back into the previous chamber. This would be determined with an echocardiogram. They can also look at how the pump works. Is it coordinated? Is it synchronized? One of the last types of diagnostic testing we're going to cover is stress testing. This is where we can use a treadmill and actually stress the heart into an exercise pattern to determine whether or not there's any areas of ischemia. Does the heart tracing that's being taken during the activity, does it show a T wave that becomes inverted or increased, showing a lack of oxygen? This can be used to predict the possibility of an infarction in patients that are going unsymptomatic otherwise. Now we're going to backtrack and look at EKG prints. And what we have on the screen now is an EKG tracing. The first area that you're looking at, or that first little hump, is the P wave, and this is what we were talking about when we're talking about atrial conduction. The straight line after it is the R, or the PR interval. And when we talked about heart block, this would be the measurement that would become prolonged, greater than the 0.12 or 0.20 pattern, to something longer, and this would show delayed conduction. The next area we come to in this nice upside down V is the QRS complex. When we are looking at premature ventricular conduction, ventricular fibrillation or ventricular tachycardia, we're looking at this large beat that's occurring in repetition. This is the QRS complex. It should only be 0.4 to 0.12. And on your EKG tracing, there would be little blocks to indicate these measurements. The T wave is the next major hump we come to. The T wave is used frequently to look at electrolyte disturbances, in particular potassium. It also is a way during the stress test to look at ischemia in the heart. The segment leading into the T wave, that nice straight line, can become elevated, and the T wave can become inverted if in fact the patient is lacking oxygen. The last little hump on there that looks like the beginning of the Allegheny Mountains is an area called a U wave. And some patients will have this. When you do find it, you want to be looking at potassium problems, but in some individuals it just exists. Now, what do we do for some of these rhythm disturbances? One of the things that we're going to try and look at first when we're dealing with rhythm disturbances is the cardiac monitor. What can the monitor show us that's going on. Now, I'm not saying we're looking at a machine over a patient. We know we always evaluate the patient first. But we're going to correlate what's going on the monitor with what the patient is describing to us. The monitor will run all the time so we can have our EKG tracing, but what we will find in turn is we will correlate that to symptoms that they're experiencing, such as pain or fluttering. One of the other interventions that we can use is medications. We can use two types of medications to try and prevent the development of heart problems, antiarrhythmics and antilipids. Examples of antiarrhythmics are lidocaine, quinidine, and procainamide. These are used to try and decrease ectopic foci. Examples of antilipids are Mevacor or Questran, which is used to decrease cholesterol. Defibrillation is the type of emergency intervention we would use for ventricular tachycardia and ventricular fibrillation. Pacemakers is the intervention we would use for heart block. Now let's backtrack and look at a presentating slide that shows a comparison between defibrillation and cardioversion. As you can see on the slide, defibrillation is an emergency treatment that is done in conjunction with CPR. And what we are doing here, remember, is attempting to try and neutralize the heart electrically so that we can get it back into its normal rhythm. We are going to start with 200 joules. If it is unsuccessful in putting the patient into a normal rhythm, we are going to go to 200 to 300 joules as a second attempt, and then 360 joules as a third attempt. There is medication that is used, CPR is continued, and we do watch the monitor. Now, frequently ACLS will alter the amount of joules being used and these algorithms for emergency intervention. So you do need to monitor ACLS standards in order to stay up to date on these emergency treatments. It is important to check the monitor between these shocks because assessing the patient is causing you to waste time. We need to get the shocks delivered so that we can get the heart functioning again. Cardioversion, on the other hand, is an elective procedure. It requires informed consent and is frequently used for non-life-threatening cardiac arrhythmias such as atrial fibrillation. Valium is usually given to the patient IV prior to the procedure to keep them calm. I think any of us would find it nerve-wracking to have somebody planning on shocking our chest with electricity. It is synchronized on the R wave. In other words, we are not going to just shock at any point in the cycle. We're actually going to wait for that R wave to appear on the EKG. The machine is going to tell us that we're at the right spot. The machine is going to deliver the shock to the patient. You just need to keep the paddle stable. As we look at other issues underneath cardioversion, the amount of joules used are reduced, 25 to 360 joules. We are going to use the least amount necessary. We will have held this patient's digitalis preparation for 48 hours prior to this because it prevents this from working effectively. And again, we're going to look at the monitor between shocks. This is the only exception to looking at the patient. Now, if we're going to be using a piece of equipment like a pacemaker, remember this is going to be used for someone who has a slow heart rate. We're going to intervene by giving them equipment that will help either take over the rhythm of the heart and tell it when to respond or supplement when it's too slow. Once the pacemaker is inserted, one of the things that we want to monitor is the rate and the rhythm. Is it working effectively? Whatever rate is set on that pacemaker, we want to see no more than a 5 beat per minute difference around the preset rate, which is usually in the 70s. We're also going to assess this patient for infection. We've put a wire in through the chest wall into the muscle of the heart. It's important to watch for signs of infection, and you know those. This wire could attach to both the atrium and the ventricle, depending on which of the two areas or if both need to be stimulated. We're also going to be looking for bleeding, because again, we're attaching to a vascular organ and we've gone through a vascular system to get there. And we need to make sure that the patient gets frequent periods of rest. They've usually gone into this procedure somewhat fatigued, so it's very important for us to make sure that we give them time to rest and let this area heal. This has been surgery, even though they may have been awake during it. Once the patient has been discharged, it's important to remind them as they go through airports on their wonderful vacations to be hand scanned. This is a metallic device. It has a magnet within it, and if we allow them to be manually scanned, they can avoid that area of the chest where the pacemaker is. If in question, they actually show the scanning guard that they have the pacemaker. And many of us remember years ago when they could not even use microwave ovens because the ways were not protected enough. So at least we've gotten beyond that. Cords from electric razors are another thing that you don't want draped across. You don't want an electrical source coming in contact with your pacemaker. In addition to hand scanning, they're going to avoid any other type of magnetic field. Now, I'm not sure exactly where all we run into magnetic fields, except on maybe military bases where they have a lot of conduction, electrical voltage and stuff. But what we need to make sure is that these patients are aware of where they're going. They will carry documentation of the type of pacemaker as well as the settings that are on it. The settings on a pacemaker can be demand, in that it only beats when you need it to. They can be fixed, where it beats all the time, where it senses the atrium, where it senses the ventricle and its functioning, or it can sense both and respond as needed. So we need to look at these issues in determining what type of pacemaker. Frequently, a patient with a myocardial infarction does not need a permanent pacemaker. They can use an external or temporary pacemaker in order to get them over the hump of the critical period. And this is because once we can get oxygen to the area that has been wounded, it should pick up with its own rhythm again. Now we're going to transition out of heart problems, and we're going to transition into head injuries, another emergency procedure. Head injuries and the things that you need to know include terminology and the nursing care surrounding it. Let's begin by looking at assessment of a head injury. Head injuries can take on a couple types of injuries. One can be a skull fracture, and with a skull fracture, the patient usually presents with some type of bruising signs. Battle sign is ecchymosis, or bruising, over the mastoid bone. Raccoon eyes are bruising around the periorbital area. Concussion is another type of head injury. Remember, with a concussion, the patient can have a temporary loss of consciousness or a decreased level of consciousness. There should be no neurodeficit, and the loss of memory should only center around the event, not any time period way previous to that. They also may present with a type of headache. Concussions can come from auto accidents, and when we develop a concussion in response to an auto accident, it's called a contra-coup injury. Contra-coup is when the head has been jarred forward and then back, so the injury takes place on the back of the head, not the front. And these injuries can result in vision changes because we need to know where the different portions of the brain are and what their functioning is. Let's go on and look at assessment of head injuries. Contusion is another type of head injury, and this can result in either a slight loss of consciousness or coma. Contusion is bruising, and it can evolve over a 24-hour period of time as we bleed into that area. When patients develop head injuries, they can develop some strange posturing. Decorticate posturing is when there's flexion and internal rotation of the forearms and hands. Let me demonstrate this for you. Decorticate is the drawing up of the arms, so the patient isn't extending, they're flexing towards you. With decerebrate posturing, we're going to get an extension and rotation of the arms. So remember, decorticate is flexion, decerebrate is extension. Now let's go back to the slide. The next thing that we may see with a head injury patient is a laceration, penetration with some bleeding of the scalp. Bleeding can be visible, or the bleeding can be hidden, and it depends on the depth of the injury. Now, as we continue to look at assessment of head injuries, there's two types of head injuries that we want to look at. The first one is epidural hematoma. Epidural hematoma occurs between the skull and the dura, and it's usually an arterial bleed. So it's important to observe this patient not only for 24 hours, but sometimes for weeks to months. The symptoms: short periods of unconsciousness, ipsilateral pupillary dilatation. What's ipsilateral? Right, same-sided. Contralateral weakness of the extremity. Contralateral means opposing. If my head injury is on the right side, my right pupil will be dilated, my left side could have weakness. As we move on to the second type, subdural hematoma, these are usually venous. They can be symptomatic usually within 24 hours. But the symptoms develop slower. Here again, we've got a decrease in level of consciousness. ipsilateral pupillary dilatation, contralateral weakness of the extremity, but oftentimes some personality changes. Remember, personality is centered in the frontal lobe. Let's go on and look at what we're going to do for the patient with a head injury. Remember that with a head injury, one of the first things we're going to do, as if any emergency situation, is immobilize the patient's extremities and neck in particular. We're going to look at the level of consciousness, their vital signs, their intake and output. Are they urinating? Are they urinating more than they should? Is their blood pressure dropping? Do we need to hydrate them? Being careful not to do anything to increase intracranial pressure. We're going to assess the pupillary size, the shape, equality, and reaction to light, as well as looking at the nose and ears for any leakage of clear fluid that could be cerebral spinal fluid. Remember, this is checked by using a sugar strip because sugar is in cerebral spinal fluid. Hypothermia is another type of thing that we would look for in head injury. Remember, with the Croup injury, we can have twisting of the brainstem, and when we get twisting of the brainstem, our vital center is in there, our thermal mechanism, the thing that tells the heart to beat, us to breathe, and recognizes our temperatures. So we would want to be evaluating hypothermia. As we move on and continue to look at some implementation, we may institute some drug therapy. Barbiturates could be used to decrease the cerebral metabolic rate. This is done not only to try and rest the patient, but also will help with the prevention of seizures. The patient would also be on seizure precautions. Their head of the bed is going to be elevated 30 degrees. And we're going to continue to watch their coordination, even though we're going to give them something to calm them down. Glucocorticoids is another drug that we can be using to treat the patient. Glucocorticoids cause a decrease in cerebral edema. Procedures should be minimized in this patient because any activities such as rolling, moving, suctioning, repositioning can increase intracranial pressure. Now let's go on and talk about chest trauma. What do you need to know about trauma that would involve the chest cavity? One of the first things that you're going to want to look at is chest tubes. The second thing we're going to look at is thoracentesis. Now we're going to begin by looking at an assessment of chest trauma and then go into the two pieces that we would use to intervene. Assessment of chest trauma can result in two types of problems, actually three types of problems. The first type that we're going to look at is called the flail chest. A flail chest is when we have fractured ribs that interfere with inspiration and expiration of the side that has been injured. And so what happens is we have one side of the chest that rises and falls normally, but we have the other side of the chest that does not go up and down on inspiration and expiration correctly. A sucking chest wound is another type of chest injury. A sucking chest wound has a sound with inspiration or respiration that sounds like you can hear the air not being inhaled through the mouth, but in fact being inhaled through the side of the chest. These patients have pain. The area over the injury will have a decreased breath sound. Air is not being exchanged normally. And they are extremely anxious with a weak, rapid pulse. Now, as we go a little further, we can look at a pneumothorax as another type of chest trauma. Sucking chest wounds and pneumothoraxes will require a chest tube, and we're going to talk about those in a minute. Pneumothoraxes result in shortness of breath or dyspnea, pleuritic pain, restricted movements on the affected side, decreased breath sounds, usually a cough that's fairly weak because it's painful to cough very hard, and hypotension. Remember, what's happening here is we have altered the intrathoracic pressure from being negative to now equaling the outside, which now makes it positive. When we get positive air into the pleural space, it causes the lung to collapse. So wherever the injury is, that lung is no longer inhaling and exhaling normally. So what do we do for this patient with this chest trauma? We're going to need to evaluate their respiratory status with the use of ABGs, look at their pain management, and make sure that they are not going into shock. Signs of shock, remember, are a decreasing heart rate, increasing respiratory rate. We're also going to provide them with some humidified oxygen. We need to make sure that since only one lung is functioning, that we are getting enough oxygen in order to prevent any type of circulatory collapse. We are also going to do a thoracentesis. which would be to pull off any fluid. Now this would be used in the case of a cancer patient or someone with HIV who is developing fluid, pleural fluid that's collecting in the pleural space. It's narrowing the area where the lung can expand, say on my right side, and we need to go in and tap that off because that restriction is giving me the less of ability to get oxygen in on my right side. If I have a sucking wound, my intervention is going to be very different. In that case, we're going to go to a chest tube. And remember that with a chest tube, we can use what's called a pleurovac. And we'll go into more detail with this later, but this is a pleurovac. One section of this would be connected to the patient. Another section of this would be connected to the wall to provide suction. And there's 3 chambers here so that we can withdraw fluid, blood, secretions, or air, as in a pneumothorax, off of the lung, and yet try and cause the lung to re-expand at the same time creating that negative pressure that we talked about. Now as we move forward a little bit here, we're going to get into some other types of injuries, and the next one we're going to come to working from the chest down is abdominal injuries. Abdominal injuries usually present with some nausea, vomiting, and bleeding. They will have ecchymosis, and the ecchymosis can take on a couple different forms. Pain may center around this bleeding and ecchymosis with rigidity and distension, but remember we do not get rigidity and distension of the abdomen until the bleeding has gone on for a long period of time. It's not going to be the first symptom. So Cullen's sign, which is umbilical bruising, Turner's sign, which is flank bruising, both represent retroperitoneal bleeding, but are not going to be there immediately at the time of the insult. Blood has to flow into the area to cause this bruising to occur. So we will not see these immediately on assessment, but we'll see these developing over time. The other type of sign that we will be looking for is balance sign. And this is a resonance that occurs over the spleen if the spleen is ruptured. It's a change in that dull tone that we would expect to see when we percuss that area. Resonance over the liver would be another unusual sign. Remember that the liver should be dull. Resonance would indicate the fact that the liver is bleeding. It's not a solid organ and it's not encapsulated any longer. In this case, we would need to go in and do a CAT scan or possibly a laparotomy to find out what types of internal injuries we have. Now, what additional interventions can we use with this patient with abdominal injuries? The first thing we're going to do is put the patient on nothing by mouth. We'll make them NPO, and we're going to drop an NG tube. The NG tube helps to keep the stomach empty. It also gives us an idea where the patient might be bleeding from. We're going to be looking at intake and output, drainage that comes out of any wounds, including from urine and stool. We're going to be looking at bowel sounds, central venous pressure, and we will also get blood gases, again to make sure that the body is oxygenating, but also in this case to make sure that we're not developing any type of acidosis or alkalosis. Cardiac monitoring would be instituted. Sometimes PVCs can be an indication of hemorrhage. The body is not getting enough oxygen because the amount of blood that's flowing has decreased, and so cardiac monitoring can help us determine whether or not there's other problems going on. An indwelling catheter will be used to make sure that we get accurate outputs of urine, knowing that we need to see 30 cc's an hour to have adequate renal functioning. Remember that the kidneys will shut down if the brain or heart are going to be compromised of oxygenated blood. As we move on to look at issues of shock, some of the things that you would need to know when you look at shock are what are the symptoms of shock? What are the types of shock? And what is the nursing care surrounding shock? Now remember on the Nclex, they're not going to get picky about which little teeny sign or symptom are we in the warm phase or cold phase. These are trends. We're looking at traditional signs and symptoms of shock. So how do we assess for shock? When we look at shock, we initially hope that we don't see as our first sign or symptom cool and clammy skin. But oftentimes we don't see the decreased blood pressure and increased heart rate immediately. And so when we get in to see the patient in the emergency room and are at the scene of an accident, at this point they are compromised. They are hypotensive and they will have cool, clammy skin. They also may have developed some cyanosis. And at the time that you start to develop some blueness, you're also going to see a decrease in the level of consciousness or their alertness. They may not be able to tell you at this moment what has happened. As we compromise respirations, heart function will follow. So as our respiratory effort goes up to try and get more oxygen in, the heart rate is also going to go up. But as with shock, we know the blood pressure drops. We have bleeding. We are losing stroke volume. We're losing cardiac output. Shallow rapid respirations follow, and this is the body's attempt to quickly get some fast oxygen in there. And in response to the heart and lung not working optimally, the kidneys start to hold on to urine, so we get oliguria. As we start to look here at what causes shock, remember that the driving forces for these shocks can also lead us to how we're going to treat them. The first type of shock that we're going to look at is hypovolemic shock. Hypovolemic shock can be caused from hemorrhage, diabetes, and this would be somebody who's in diabetic ketoacidosis, or internal sequestration such as what occurs with fractures, a hemothorax, ascites, or that compartmental syndrome that we hear about when we've trapped blood underneath a cast or at an orthopedic site. This is where we have a change in intravascular or extracellular fluid volume, what is circulating throughout the circulatory system itself. We also have a type of shock called normal volume shock, normal volemic shock. This is where we have a disruption between the vascular size and the volume that's circulating. Cardiogenic shock is an excellent example of this. The heart is not functioning adequately, so it cannot pump adequately. There's nothing wrong with the volume, the pump mechanism is faulty. Neurogenic shock is what we create when we put somebody under anesthesia, when they develop a reaction to insulin, or they have a spinal cord injury. Again, this is the nervous system is driving the hypotension that occurs in this type of shock. In order to correct this shock, you have to correct the problem with the nervous system. Vasogenic shock is another type of normal volemic shock. Vasogenic shock is anaphylactic shock, which occurs when we've been exposed to something we're allergic to, a bee sting, a food item, or toxic shock that comes from the long use of tampons associated with menstruation. Now, when we have a patient who's experiencing shock, the implementation or treatment for shock is not so different. We need to maintain oxygenation, which means maintaining a patent airway, and either giving them oxygen by cannula or on a ventilator if necessary. We need to find a way to increase tissue perfusion. We need to keep them warm. This helps with perfusion. We need to give them fluids. And our goal is to maintain the systolic blood pressure higher than 90 millimeters of mercury. We can also monitor hydration by looking at the central venous pressure. Central venous pressure in the low numbers 3 and 4 show hypovolemia. Central venous pressure numbers that are in the high teens show overhydration. So as we begin to hydrate this patient, we want to make sure that we do not overhydrate them. So one method of monitoring hydration would be the CVP. Hourly outputs is also a way to determine whether or not the kidneys are now getting enough oxygenated blood and can function normally, as well as is the body getting enough fluids. Remember, urinary output would be monitored through an indwelling catheter, and we're looking at 30 cc's an hour or more. Continuing with implementation for shock, we get in looking at ABGs. It's important to determine in shock whether or not the patient has acidosis. If in fact they do, we would be giving them some sodium bicarbonate and looking for the cause of the acidosis. We want to maintain their body temperature. Remember, chills use oxygen. Also, chills is constricting and cuts down on the circulation to extremities. As long as we've been able to maintain body temperature, the next thing that we need to do is look at bed rest. Here we're going to elevate the extremities about 20 degrees, keep the knees straight, we don't want to put pressure on the popliteal space, and slightly elevate the head. This is different than the old Trendelenburg positioning. Trendelenburg actually decreased the ability to breathe because the head was lower than the diaphragm. The next thing we're going to do is give large volumes of fluid, and these are not in necessary order. We know that with shock, the first intervention would be to get a large bore IV needle in and get fluids into that patient. We need to get them hydrated. We're going to give them large volumes of plasma expanders or electrolyte solutions, such as 0.9 sodium chloride. Medications that we can use for these patients include antibiotics, cardiac glucosides, diuretics, and adrenergic or sympathometics. What we are trying to do here with these drugs, in the case of the antibiotic, is treat infection, if that's the type of shock that is being caused. With glucosides, we are looking at trying to improve the pumping action of the heart, as in cardiogenic shock, by using digoxin, isopril, atropine. Diuretics would be used if we have a shock volume where we're trying to decrease the holding of fluids. This would be used in neurogenic types of shock with increased intracranial pressure. Here we would use a drug like mannitol. And then with the adrenergic type ones, we're looking at the Dobutrex, dobutamine. These are drugs given to try and raise the blood pressure in conjunction with the use of hydration. Increased intracranial pressure is the next thing I'd like to discuss. So we're going to transition out of shock. With increased intracranial pressure, some of the things that you need to know are the Glasgow Coma Scale, which is used to evaluate alertness, symptoms that would be present in the case of increased intracranial pressure, medications that would be used to treat it, and then of course the nursing care that surrounds this patient. We're going to begin by looking at assessment of increased intracranial pressure. When we look at assessment of increased intracranial pressure, one of the earliest signs or symptoms of change is, right, level of consciousness. Are they alert? Are they oriented? And from this we can use this to help us identify where they stand on the Glasgow Coma Scale. We know that anything less than 7 shows coma. Now on table 4 in your book, you have a copy of what we are evaluating: their level of alertness, their orientation, their eye movements, their verbal response, and their motor response, each having a criteria that we measure to determine this figure. We're also going to look at whether or not the patient is confused, restless, or has any pupillary changes. Again, we're looking for the earliest signs that we can pick up that there is a change. Vital sign changes would be another thing that we would be monitoring for, and here we're looking for a widening pulse pressure. As we move forward looking at increased intracranial pressure, let's take a minute to look at implementation. One of the important items to look for here is monitoring the vital signs hourly. Remember, we're looking at pupils, motor, respiratory functioning, as well as continuing to monitor this Glasgow Coma Scale: alertness, verbal response, motor response. We're going to elevate the head of the bed 15 to 30 degrees. Remember, this is a hallmark thing to do to decrease intracranial pressure. Get the pressure down, elevate the head. And we want to avoid any neck flexation or rotation. We want to decrease the amount of movements that we do because movements increase intracranial pressure. We're going to immobilize this patient as much as possible. In addition, we're going to try to reduce the environmental stimuli. Environmental stimuli can make patients restless. This increases intracranial pressure, as well as preventing the Valsalva maneuver. This can be done very easily by putting someone on stool softener or using enemas so that they do not have to bear down to defecate. We're going to restrict. Now, you heard me say restrict fluids to 1,200 to 1,500 cc's a day. We do not want someone with increased intracranial pressure overhydrated. We're going to give them medications to not only try and help with the issue of keeping them slightly dry, but decrease the amount of swelling in the brain, as well as decrease the risks of seizures. The drugs we're going to use are osmotic diuretics, corticosteroids, and anticonvulsants such as Valium or Dilantin. Seizure types are listed in Table 5, and they go from being grand mal to being petit mal to going into those that are generalized to being localized. And you need to review those types of seizures. But what we want to talk about now is what are the implementations, what do we see with a seizure, and then how do we intervene to help the patient who's having a generalized seizure. We're going to begin with looking at implementation during a seizure. The first thing we need to remember is that we need to protect the patient from injury. We do not want to restrain them. We do not want to shove a bite block into their mouth once their teeth are clenched down. We want to loosen their clothing so they can move and breathe. And we're going to monitor both the onset, duration, and pattern of this seizure so it can be documented. We're going to notice, did they have an aura? Did this seizure take place all over the body or only in the arm? Was it a staring seizure? Was there foaming at the mouth? Did they urinate? Can they remember what happened before or after? We're also going to, following the seizure, position them on their side. This allows aura secretions to drain, especially in the case of a grand mal seizure, which usually causes a lot of fatigue and a little bit of depression afterwards. These patients aren't extremely alert, they're tired. We're going to reduce environmental stimuli. Noises like the old metal bedpans was enough to give somebody a stimulation to have a seizure. We want a quiet environment. Because we're looking at anything that can help with brain functioning, we want to make sure the patient is getting enough oxygen, that this period of time during the seizure they did not become hypoxic. We're going to suction any secretions that are collecting in the mouth or oral or nasal airway, and we're going to try and continually reorient them following the seizure. They need to know what has happened, where they are, and who is with them. One of the big nursing things we do with seizures is trying to teach patients about medication. It's important for them to remember that we are not going to discontinue medications abruptly. We are going to avoid all use of alcohol with anti-seizure medications. We are also going to make sure that they maintain good oral hygiene. We know from reviewing the anti-seizure medications that many of them cause the membrane or the tissue in the mouth to deteriorate. And we also want to make sure that they have an ID band that identifies them as a patient who has seizure disorder. Now let's transition out of that into the CVA patient. Here's where we have a cerebral vascular accident patient, and we're going to look at some issues surrounding the assessment and implementation of this patient. Let's begin by looking at assessment. One of the first things that you're going to see with a patient who has developed a CVA is confusion and disorientation. There may be some changes in their vital signs and their neurological status. They could be having a seizure, they could be disoriented to where they're at. They could also have some aphasia, which is difficulty speaking, hemiplegia, which is weakness of the opposite side where the infarct would have taken place or the clot would have taken place, incontinence, either of bowel or bladder, dysphagia, which is difficulty swallowing, or hemianopsia, which is loss of the half of a visual field. Now, as we start to look at these, we have to think about what are the causes of CVAs. Why does a patient develop a, quote, stroke? Remember, this can occur from an occluded vessel like a thrombus. It can be a result from low volume in that the brain wasn't getting enough oxygen, or it could be a spasm or a hemorrhage that has taken place. Remember, these are the patients that have hypertension, diabetes, renal failure, smoke excessively, don't exercise, and we know the risk factors associated with a stroke patient. When we get into implementation during the acute phase, remember we have two phases here. We've got to treat the acute illness or the incident as well as get them ready for rehabilitation. We want to maintain a patent airway. It's important to make sure that if they have problems with swallowing, that they're not holding secretions in their mouth. If they're going to be nauseous or vomiting, that these secretions don't get trapped. So we need to keep the airway open. We also keep the head elevated. This serves two purposes. If their head's elevated and they're turned slightly to the side, oral secretions can drain. We also make sure that the intracranial pressure stays decreased. We're going to minimize activity. We want them resting. We don't want them becoming more frustrated because they continually are reminded that one side of their body doesn't move correctly. And we're going to institute measures to facilitate swallowing. As far as instituting measures to help with swallowing, they can range anywhere from having the patient be nothing by mouth initially to putting in swallowing precautions. Remember, with swallowing precautions, we would not rush into the room to give this patient water to drink, especially not milk. It's a very thick substance to swallow. We're going to thicket or make the liquids more like a pudding substance. It's easier for them to use tongue motion to get these foods to the back of their mouth. They're less likely to choke on them. We're also going to have their head of the bed elevated and keep them leaning slightly forward. They will also remain elevated for 30 to 45 minutes following any meal to make sure that they do not aspirate on anything that they've eaten. Now, as we move from the acute phase into the rehab phase, it's important to remember that we need to take care of the skin and the muscles. We're going to orient this patient to time, place, and person, but we're also going to get them involved in their routines with care. They need to remember that they need to change position. They need to remember that they have braces that go on to help with mobility. We're going to look at communication problems. We could be talking to this patient and they understand us very well but can't answer us. Or we can have a patient who doesn't understand a word we're saying and talks to us in a garbled language, or a combination of both. We need to find a way to communicate with them so we know their needs. We're going to put their body through range of motion exercises a few times a day. These patients go into a vigorous physical therapy program, again supporting joints and muscles so that the body can become strong and adaptive and overcompensating for the weakness. We're going to look at elimination problems and skin care needs. And the reason these go hand in hand is that if we allow a patient to remain in incontinent urine or stool, the patient's skin is going to break down. And so it's important for us to make sure that not only do we turn them so they don't develop bed sores, but we keep them clean and dry. We also do not want them to develop the complications of constipation or urinary retention. Now let's move out of the CVA patient and look at a spinal cord injury patient. As we look at spinal cord injuries, we need to look at how do we assess that this injury, where this injury has occurred and what's going on with the patient. We need to look at the loss of sensation below the level of the injury. We're also going to be looking at spinal cord shock. Remember, spinal cord shock is a flaccid paralysis, loss of sensation, no pulse, and that's because there's no communication going on in the nervous system in that part of the body. Postural hypotension occurs in response oftentimes to a spinal cord injury, as well as changes in the ability to regulate temperature. They also may develop some edema at the site and develop some restlessness because of what they see going on. Now, as we move into implementation a little further, it's important for us to look at providing ABCs. Remember, if this is a neck injury, it's going to be very important to immobilize the patient first before we open that airway. We don't want to do any further damage to the neck or the cervical spine. We're going to look for stabilizing vital signs. We need to get their blood pressure stabilized. We need to bring their heart rate down, get them relaxed. Immobilization may take the forms of a soft collar or the use of skeletal traction, fusion, pins, or rods. And in the event of having to turn these patients, it's important to make sure that we log roll, that we use turning frames so that we can get them off of their back and onto their stomach. Circle electric beds, or we can get them out of the lying position into a little more upright position. Remember, this helps with bone density. We're going to be looking at nutrition needs as well. But as we continue into spinal cord injury, we're going to also be looking at what drugs do we use. Steroid therapy is a hallmark treatment for spinal cord injury. We have seen it used on a football field with an injury that they know is serious. Giving steroid therapy at the earliest possible time decreases inflammation and can drastically limit the degree of injury and permanent damage. Hyperbaric oxygen can be used. This is a way to supersurge the body with some oxygen. Bladder and bowel training through the use of catheterizations or bowel regimens are instituted to try and keep these body systems functioning optimally. The patient needs emotional support, and this requires a lot of not just support for the patient but the family as well, and looking for a way to involve both the family and the client in teaching and identifying what their rehab needs are. As we look at the type of injuries that a spinal cord patient can have, remember that an injury above C3 means that that patient will be ventilatory dependent. And Nclex likes to ask you, what is the adaptive ability of these patients? A C4 injury, they can use a wheelchair and power device them. They can't roll it, but with power mechanisms they can operate it. C7, they would be independent to be able to dress themselves in a wheelchair, and L3 through L7 could actually allow someone to be able to use canes or supportive devices to be ambulatory. Now, there's more information about this on the table of injuries associated with spinal cords. One of the complications that can occur to a spinal cord injury patient is autonomic hyperreflexia or dysreflexia. When we're looking at causes of autonomic hyperreflexia, one of the primary things to look for is bowel and bladder dysfunction. Has the patient defecated? Is their bladder distended? Do they have pain? Do they have tactile stimulation, something rubbing them on an area that's irritating? You know, this frequently occurs in patients with a T6 injury or above. And what you are looking for is, in the assessment process, blurred vision, headaches, diaphoresis, piloerection, which is goosebumps, bradycardia, and most importantly, hypertension. The patient becomes red above the injury and pales out below the level of injury. This can become a hypertensive emergency. The primary thing that we need to do is find a way to get the blood pressure down with whatever intervention we take on. Now let's look at some of the treatments for autonomic hyperreflexia. When we're looking at this, the first thing that we're going to want to do is find a way to empty the bladder or the bowel if it can be done quickly. If not, elevating the head of the bed will drastically reduce the hypertension, prevent any increased intracranial pressure. If we cannot catheterize quick enough, we may need to resort to the use of IV antihypertensives such as apresilene. It's given slowly. But like I said, the key thing to do is get this patient sitting upright. This may be enough to be able to bring down the blood pressure effectively. Now this ends part 1 of this unit. We'll start up the next tape by looking at fluid and electrolyte imbalance. Thank you. Hi, welcome back to part 2 of physiologic adaptation. We're going to begin this unit by looking at fluid and electrolyte imbalances. Remember, you can follow along in your book with these, and we will be talking about values related to the electrolytes. When we begin to look at fluid and electrolyte imbalances, some of the things that you need to know include symptoms of fluid volume deficit and excess, and tonicity of IV fluids. Are they hypotonic, isotonic, and hypertonic, and which ones are indicated in which instances? Let's begin by looking at fluid volume imbalances, and we'll begin by looking at some of the normal ranges. Remember that on Nclex, this is the one piece of information, unfortunately, that you do have to have memorized. So when you get into Sylvan, write down these values right away so you don't have to remember them throughout the test. Potassium, the normal range is 3.5 to 5.0. It's the main intracellular ion and is involved in cardiac rhythm and in nerve conduction or transmission. Sodium, normal range is 135 to 145 milliequivalents per liter. It's the main extracellular ion. And remember, this is the one that's responsible for fluid balance. We know that. We eat ham for dinner, we feel bloated the next day, or our rings are tight. When we look at the next, we go on to look at calcium. Normal ranges are 4.5 to 5.2 milliequivalents per liter. And this is used for blood clotting, skeletal muscle contraction, which would include the heart, and is regulated by the parathyroid hormone and vitamin D. Remember that thyroid surgery can affect the parathyroid gland and thus affect calcium. It also has a sedative effect on the central nervous system. Magnesium is the fourth electrolyte we will look at, and it's 1.5 to 3.0 milliequivalents per liter, and this acts as a depressant. And so let's move on and start to look at some of the signs and symptoms of fluid volume deficit as well as fluid volume excess. Now we'll begin with deficit. Fluid volume deficit usually presents with a rapid, weak pulse, hypotension, increased respirations, poor skin turgor and weight loss, dry mucous membranes, an increased hematocrit, and increased specific gravity above 1.030. The BUN may also increase, as well as the CVP reading we talked about previously may decrease. What's going on here in this patient? A patient's developed fluid volume deficit through vomiting, diarrhea, excessive use of diuretics, or possibly GI suctioning. What do we do for the patient who has fluid volume deficit? These are dry individuals. The first thing that should come to mind is to hydrate. If they are not in the hospital, they need to force fluids. Symptoms like fluid volume deficit can develop gradually over time, and patients can correct some of these at home if they've been educated. If they have extreme fluid volume deficit, we need to start them on isotonic IV fluids, such as lactated ringers or 0.9 sodium chloride. We are going to monitor their intake and output and weights to determine how they are responding. Remember, the hourly urine output should be increasing above 30 cc's an hour. The specific gravity should be decreasing. And remember, Nclex likes to ask us how we know if someone is improving. If they have fluid volume deficit, as they improve, the symptoms would resolve. We're going to look at their skin turgor. Do they still tent, or does the fluid look like it's back in the tissue? And like I had said previously, we were going to look at specific gravity. And we're hoping that this is going to approach 1.020 as a norm. You must recognize signs of improvement. You must be able to recommend what further treatment might be indicated by the physician. Now let's move on and look at fluid volume overload. Here we have a patient who presents with a bounding pulse. They also are usually a little bit restless. They have an increased blood pressure. There's too much circulating. as well as some shortness of breath, and may have developed a murmur also. They have crackles in their lungs or rales, and this is because we have so much circulating fluid that the alveoli become puffed up and the fluid actually seeps from the tissue into the alveoli spaces, and we can hear that with breathing. Peripheral edema occurs, and on top of this they may develop some jugular vein distension or neck distension of the carotid artery. Their hemoglobin and hematocrit will decrease, as well as the BUN. Now, the specific gravity in this case would be less than 1.010. We're going to have a CVP reading that is increasing with fluid volume overload. But let's talk a minute about what happens with hemoglobin and hematocrit in both of these cases. When a patient is overloaded, like we're talking about right now, the hemoglobin and hematocrit become diluted. And so what happens is we get a false decrease, and the patient may appear as if they would be hemorrhaging. This is purely from dilution. As we give them diuretics or dry them out, the hemoglobin and hematocrit will come up to a more normal range. The reverse would be true for someone underhydrated. We would have a falsely elevated hemoglobin and hematocrit. Let's look at some of the indications for treatment for fluid volume deficit. The first thing being, let's get rid of the fluid. Give them a diuretic. A loop diuretic like Lasix could be used. We're also going to restrict the amount of fluids they take in and the amount of sodium in their diet, remembering that sodium holds fluid. We're going to assess breath sounds and check for edema. The edema that we check for is not just in the hands and feet, but remember it also occurs in the sacral area, especially on someone who's on bed rest or sitting. A semi-Fowler's position is going to be used. This patient, if you remember, can be complaining of shortness of breath and have some rales and crackles. So it's very important for us to make sure we keep the head of the bed slightly elevated, 45 degrees or so, to cut down on the respiratory difficulty. Now, what kind of conditions can cause changes in fluid volume? One that should jump to mind would be conditions that involve the posterior pituitary gland. Here we deal with oxytocin, vasopressin, and ADH, the anti-diuretic hormone. Let's begin by looking at one type problem. Here we're going to look at assessment of diabetes insipidus. Remember, diabetes insipidus is a decrease in ADH. Our body does not have enough of anti-diuretic hormone. We cannot hold on to our fluids. We become underhydrated. These patients present with excess urine output, severe dehydration, excessive thirst, weakness, a decreasing specific gravity, and an increasing serum sodium level, as well as some weight loss. Now remember, with ADH, sodium is acting as a different precursor in this situation than when we're dealing with volemic or hypo or hypervolemia problems. Sodium, when we're dealing with diabetes insipidus, is increasing because we're getting rid of fluids, but the sodium does not go with it. So as we dry out, the salt increases. It would be like too much sun on the ocean, evaporating the water and leaving the salt behind. What do we do for this patient with diabetes insipidus? One of the first things is going to be to monitor their intake and output. How much are they eliminating? What is their weight doing? How are their vital signs? Are we seeing any improvement with our interventions in their blood pressure? Has it started to increase slightly? And what's going on with the specific gravity? Again, if we're looking at specific gravity, we want to see changes that approach the norm, 1.020. And one of the hormones that we can give to try and correct this would be pitressin. It's given in a nasal spray, and it helps replace the deficit in antidiuretic hormone. Now, if we go on to look at another type of problem with this posterior pituitary gland, we could be dealing with SIADH. SIADH is a syndrome of inappropriate antidiuretic hormone. This patient is overproducing antidiuresis. In other words, it's holding on to its fluid. The patient usually shows signs of overhydration, anorexia, nausea and vomiting, lethargy, headache, changes in level of consciousness, depressed deep tendon reflexes, and this is because we're altering electrolyte imbalance from over volume of fluids. Tachycardia, because we've increased the amount of circulating volume, we are stressing the heart. Decreased urine output, which should make perfect sense. If we are holding on to and we are not diuresing, we are not putting out urine. Now let's think about what's happening in this patient. We have an increased circulating blood volume. We have a decreasing serum sodium because it's being diluted. This is the condition where it's raining and raining and raining over the ocean, nothing evaporating the water off, and the salt content continues to be diluted from too much water. Specific gravity in this case will start to climb because we are not urinating. The urine becomes concentrated with metabolites or minerals. So what do we do for this patient? When we look at implementations for syndrome of inappropriate antidiuresis, we want to be looking at assessing the level of consciousness and the sodium levels. These two are tied together, and as we start to talk about electrolytes imbalance with sodium, we will see that one of the symptoms of a sodium imbalance is changes of level of consciousness. In this case, it comes about for two reasons. Increasing circulating volume also causes increased intracranial pressure, and one of the earliest signs of increased intracranial pressure can be changes in level of consciousness. We have a piece going on here that is a repetitive type process. Checking the intake and output in daily weights will be used in this case to make sure that we're seeing improvement in that the weight should be decreasing and the urine output should be increasing. We do not want to be giving them a lot of fluids in this case and in fact not seeing them urinate. We are going to restrict the water intake of these patients to 500 to 600 cc's in 24 hours. If you're thinking about how much that would be, that's less than 3 cartons of milk in an entire day. 2 or 3 sodas would put them over this amount of limit. We're going to give them diuretics to also try and get rid of the excess fluid. And in this case, we're going to give them 3% sodium chloride IV in an attempt to try and help with the sodium imbalance. Now let's start to look at some of the electrolytes and what exactly happens as we have changes in sodium, potassium, calcium, and magnesium. We're going to begin by looking at hypokalemia. Hypokalemia is a decrease in potassium below 3.5 milliequivalents per liter. These patients frequently will have difficulty from overuse of diuretics, steroid use, vomiting, GI suction, or diarrhea, things that cause us to lose fluids. They will have muscle weakness. Remember, potassium helps with muscle contraction. They will have paresthesia. This is the numbness and tingling that occurs from poor perfusion, and dysrhythmias. And if the dysrhythmias, in this case, usually present as ectopic beats, PVCs. There'll be an increased sensitivity to digitalis, in that if a patient's potassium level is dropping, we're going to set that patient up for an easier time developing digitoxicity. And then digitoxicity in turn is going to slow the heart. So we need to watch potassium levels in patients that are on digitalis preparations. What do we do for the patient who has a low potassium level? The first thing we're going to do is try and supplement it. When a patient is discharged to home on antihypertensive diuretic type therapy, where we're trying to help the body get rid of fluids, we are going to encourage them to take in sources that are high in potassium, foods or a potassium supplement. In the case of a patient with a severely low potassium level in the hospital, we will add potassium to the IV fluids as well. When we think about how do we give potassium IV, we want to make sure that we do not give more than 40 milliequivalents per liter of fluid into a peripheral IV. There's 2 reasons for this. It's a cardiac irritant, and it also burns or destroys the intima of the vein and can cause thrombosis and phlebitis. Now let's look at some of the foods that we could suggest for this patient to use at home. When we've sent the patient home, we know that orange juice is a great choice. We'll tell them coffee has some potassium in it, although we don't want them on the stimulants usually. Apricots, beans, potatoes, carrots, celery, and raisins. Dry fruits and vegetables, green type vegetables occasionally have a little bit of potassium, but our primary sources are going to be your orange juice, the bananas, and the dry fruits. Now if we look at the other side of the coin, we're going to look at conditions of hyperkalemia. Hyperkalemia is a potassium level above 5.0. When a person's potassium level increases, we set them up for EKG changes that can result in asystole or cardiac arrest, requiring CPR. Who develops hyperkalemia? These are patients with renal failure, a patient who was added an antihypertensive agent that no longer loses potassium and yet they're continuing to take their potassium supplement, patients that have had burns, and those that have crushing injuries. Now, how else might they present? They're going to have some paralysis, diarrhea, and nausea. And remember, potassium has to do with contractility, and so it's important for us to look for the symptoms that would be associated with contractility. Now, what do we do with this patient who's presenting with hyperkalemia is to restrict the oral intake of potassium-type substances. We do not want to cause the potassium to rise anymore. We're also going to give them K-exolate. K-exolate causes diarrhea, but it must be given with water to work effectively. K-exolate will bring down the potassium by giving them diarrhea. Peritoneal or hemodialysis would be used in extreme cases. This is in the case of someone developing renal failure. We know that in renal failure potassium levels rise, and oftentimes we need to dialyze in order to pull that potassium level off. Diuretic therapy would be another way to bring down hyperkalemia, and in fact would be used prior to using peritoneal or hemodialysis. Now, in the emergency room, they will also have available calcium gluconate and sodium bicarbonate because potassium can change the pH of the body. Insulin and glucose is another treatment to bring down a high potassium level because what the insulin and glucose will do will allow the cells to take potassium back into it and thus lower the serum potassium level. Now, when we start to move from potassium, we start to look at sodium. And we know that when we use diuretic therapy, we alter both sodium and potassium levels. These are sharing type ions. Sodium that is hyponatremic is less than 135 milliequivalents per liter. The patient is usually nauseous, has muscle cramps, confusion, and may in fact develop an increased intracranial pressure. Remember that with hyponatremia, they may have water intoxication. We have so much circulating extra fluid in the body that we have diluted out that sodium. Convulsions can occur if we do not find a way to correct the sodium imbalance and raise it slowly. Something important to remember about sodium imbalances, they must be corrected slowly. Otherwise, we can get the reverse to occur. We go from a hypo to a hyper state. Now, what would cause this patient to develop hyponatremia? Diuretics could be used, vomiting could have occurred, we gave them the wrong type of IV solution, or we have given them too much water. Now let's move on and look at what we would do to treat the patient with hyponatremia. The first thing that we're going to do is to give them some foods, fluids, broths, tomatoes to increase the salt and watch the response in the intake and output. As we increase the sodium in their diet or in their IV fluids, we should see their intake and output start to improve. The sodium should start to balance out. Their weight should balance out. We should not have somebody who's appearing excessively bloated. We should have a balance. We should start to eliminate those fluids. We're going to increase the intake of other sodium-rich foods besides the tomato juice and broth by giving them gravies on their foods, giving salt to their tray. And this always throws the hypertensive patient off who's been told, I have high blood pressure, I can't use salt, now you're telling me to use it. Well, it's because we over-diurese them and we've altered their sodium. Sometimes it's necessary to not try to raise the sodium by any means except to restrict water. If we stop the ingestion of the liquid, the sodium can come back down into or rise up to a more normal level because we have depleted some of the circulating volume. Water restriction would be used to stop the over-dilution of sodium. The solution that we would use IV to correct this would be an isotonic solution like Ringer's lactate or 0.9 sodium chloride. Again, given slowly, we do not want to overhydrate the patient. How do we know if the patient's improving? We should see resolution of the symptoms that cause them to seek out medical care. So in this case, we should see someone whose sodium levels start to rise. We see someone if they had overhydration signs and symptoms, their weight coming down, their blood pressure coming down, some of the confusion changes. Let's look at the flip side of this. Let's look at hypernatremia. What's happening here? We have a sodium above 145 milliequivalents per liter. We have a patient who's presenting with disorientation, delusions, hallucinations. They have too much salt in their system, so they are thirsty, they're dry, their tongue is swollen, their mucous membranes are very sticky. I hope I'm making you feel very thirsty. They are hypotensive, and they are tachycardic. This patient oftentimes has low volume, and so what we need to do here is hydrate. This is a patient who may be experiencing severe diarrhea, diabetes insipidus, which remember what we talked about with diabetes insipidus, or has taken over-the-counter medications that are high in salt. Now, what do we do for this patient with hypernatremia? The first thing we need to do is look at their intake and output. What exactly is going on here? Are they urinating? Why is the sodium climbing? Is there too much output, or is there not enough fluids going into the body at all to dilute it? What's going on with their daily weight? Diabetes insipidus, the patient would be getting very thin. Remember, they're losing a lot of fluids. When we're looking at other issues here, daily weights, as we respond to a sodium intervention, we should see the weights increasing if the patient has been hypovolemic. Sodium that we're going to replace in this case is not going to be a high salt solution, but in fact a lower salt solution. This patient needs fluids, not sodium. So we're going to go with half normal saline or 0.45 sodium chloride, or use dextrose in water. These are hypotonic solutions used for hypernatremia. We're going to decrease the sodium in the diet. There's no reason to try and bring this down without limiting what they're eating. If they're loving pickles and broth and tomato juice and those things that we were using to try and raise sodium, we're going to eliminate those foods out of this patient's diet. We're also going to give them fluids if needed. Now, as we transition out of sodium imbalances, we're going to go into calcium imbalances. So let's look at what we assess for in a patient with hypocalcemia. In a hypocalcemic patient, the calcium level is below 4.5 milliequivalents per liter. The patient will develop tetany. Two of the symptoms of tetany, and remember this is a seizure type activity, a muscle twitching kind of thing, is a positive trousseau sign. This is where you have carpal spasm when a blood pressure cuff is put on and inflated on the arm. So when you're looking at this sign, remember it has to do with an arm twitching or an arm type contraction. When we're looking at the Shavastic sign, we're looking at a facial nerve response. As you tap on the face, you're going to get muscle twitching of the face as well. So here we're looking at little types of muscle spasm type responses because calcium has to do with muscle contractility. If the patient is untreated and the calcium remains low, they may develop seizures, confusion, irritability, or paresthesia. Remember, the calcium's not there to help the heart contract. It's not there to help the muscles contract. We need calcium for contractility of muscles, and they may actually develop cardiac arrhythmias and arrest. The nervous system in this case can become slightly excited, and the types of conditions that cause hypocalcemia are hypoparathyroidism, pancreatitis, renal failure, steroid use, especially excessive use. We know that Lasix, when we give Lasix, that we can have problems with the calcium dropping, as well as a decreased intake of calcium. This can be based on money. Families that do not have enough money for dairy products, milk and cheese, families who live in darkened areas and don't have vitamin D to help with absorption will end up with problems with hypocalcemia. Now, post-op thyroid patients can also develop this problem if, in fact, we injure the parathyroid gland, because parathyroid is what controls the release of calcium. Now, let's go on and look what we're going to do for the patient with hypocalcemia. The first thing that you want to look at is what kind of oral supplements can we give them. And when you do give the oral supplements, you want to give it with orange juice. It helps with absorption. We are going to give them calcium gluconate IV. And something to think about here is if you are ever in an emergency situation and your patient develops laryngeal spasm or stridor or has had thyroid surgery and proceeds to arrest, the drug of choice is calcium gluconate before anything else. If we do not raise the calcium, all other efforts to resuscitate will be futile. They will not respond. Another intervention that we're going to want to be using for this patient is seizure precautions. We want to prevent them or protect them from any seizure activity that might occur. We're also going to look at meeting their safety needs. Things that come into play here are making sure that if they're confused, we reorient them. Exercise. If we can get them to exercise, remember the bone releases calcium. So it's real important to find ways to try and help the calcium get out into the bloodstream if they've been immobile. Increasing the calcium in their diet if they're poor. We don't want them developing rickets or osteoporosis because of a poor intake of calcium. And then calcium supplements would also be added over the rest of their lifetime, even in children. But we need to monitor for the development of kidney stones. So when they're taking calcium supplements, it's very important to make sure that they're also drinking or hydrating their body. Let's look now at the other side, hypercalcemia. And what kind of symptoms does a patient present with hypercalcemia? In this case, the calcium is going to be increased, 5.2 milliequivalents per liter, and there's going to be a lack of coordination with some muscle weakness, constipation, abdominal pain, depressed deep tendon reflexes, and dysrhythmias is in the case of a slower heart rate, along with some confusion. Now, what is happening with this patient is the calcium is high. It's trying to do too much, and the body goes on overload. So we develop constipation because the contractility isn't effective. The muscle weakness comes because the contractility isn't working functionally. So what we want to do here is find out what is causing the patient to have a high calcium level. This comes from cancer. Cancer patients, frequently one of the early blood studies that are abnormal is an increased calcium level. Hyperparathyroid patients will also have this problem. The parathyroid is sending out a message to release too much calcium. And then excess intake of calcium. Here we've told the woman with osteoporosis, oh, you need to take a calcium supplement. Well, she's now, instead of taking 1 tablet, she's taking 2 because 2 would be better. So now she's driven her calcium too high. They also set themselves up in this case to kidney stones. Remember, one of the causes for kidney stones is high calcium. What do we do to try and help this patient as far as implementing some actions to correct the problem? We're going to put them on a 0.45 sodium chloride solution or 0.9 sodium chloride solution. Here we're going to try and hydrate the patient. We need to give them liquids. Remember, this is how we made sure the kidney stones didn't develop, by keeping the calcium diluted, making sure that the body can excrete any excess. We talked earlier that Lasix can cause the calcium be too low. So let's give a diuretic in this case to bring the calcium down to a more normal level. Calcitonin is also a hormone that we can give a patient to try and bring the calcium level back into a normal range. And as much as I said mobilization can sometimes help correct a low calcium level, it can also help a high calcium level. Because if the bone is trying to respond to calcium imbalances by releasing calcium too often, because we're laying around, there's nothing to keep the calcium in the bone, so it's being released out into the bloodstream with no exercise, no fluids, we're not going to excrete that calcium, it's going to continue to build up. So in this case, if we can exercise the patient, the bone won't have reason to release it. It will need to hold on to that calcium to keep it strong. Another thing that we may be able to do here is surgery. If the condition is a result of hyperparathyroidism, then we're going to go in and we're going to do surgery. We're going to limit calcium in the diet, and we're going to try and watch or prevent those kidney stones by keeping the urine acidic during the treatment of hypercalcemia. Now, the last electrolyte we're going to look at in this segment is magnesium. Magnesium is sometimes a neglected electrolyte, but it is connected with the ability of our body to respond to potassium and for us to correct potassium. So we're going to start first by looking at hypomagnesiumism. In hypomagnesiumism, we have magnesium that is less than 1.5 milliequivalent per liter. The patient usually has neuromuscular irritability, tremors, seizures, and tetany. And I'm going to stop here for a minute. This should present to you like the patient with pregnancy-induced hypertension. The patient whose PIH or blood pressure is increasing so much that they're at risk of developing seizure activities during their pregnancy. And how do we treat them? By giving them magnesium. So when you're thinking about a low magnesium level, try and think about that pregnant individual who is developing seizure activity because the deep tendon reflexes and muscle coordination is not synchronized. It's weak. And so it's out of control. Other symptoms that the patient could present with is confusion and dysphagia. Again, we cannot swallow if we don't have the electrolytes that help us intervene in that area. Dysrhythmias can occur. And we talked earlier, as I introduced this, about potassium. If we have an individual with a low potassium level and we continually try to respond to increasing their potassium with potassium chloride supplements and the potassium does not increase, it would be advantageous to look at magnesium levels. Oftentimes, when a potassium remains low and is unresponsive to treatment, it's because the magnesium level is also low. In order to get the potassium to rise, we also have to raise the magnesium as well. But this must be done carefully. It can cause a lot of cardiac irritability and can cause a patient to go into cardiac arrest. So let's talk about how to correct the low magnesium. The first thing that we want to look at is monitoring the cardiac rhythm and reflexes. We know that in the pregnant individual that we were trying to prevent from seizures and have on mag drips, that we're looking at their deep tendon reflexes. And if they start to respond with a lack of a deep tendon reflex, we need to stop the magnesium. We've given them too much. It's the same in this case. As we replace the magnesium, we are going to watch for irritability. Are the reflexes becoming hyperactive? Are they now in disaccord? When we're looking at cardiac rhythms and we're trying to replace this for a cardiac patient, it's important to look at the heart rate and to give the dose very slowly and diluted. All right, we do not give fast drips of magnesium or concentrated doses of magnesium. One of the things that we want to watch for also is the ability to swallow. Individuals that have difficulty with magnesium have airway problems. There should be oxygen at the bedside, and they should be continually checked for dysphagia. Seizure precautions would be instituted. Again, we've talked about this. It has to do with the way we would treat the pregnancy-induced hypertensive patient as well. And if we're trying to replace magnesium besides through IV use, we're going to look at what foods have magnesium in them. These are green vegetables, nuts, bananas, oranges, peanut butter, and chocolate. Safety becomes a concern here. We want to prevent them from hurting themselves with confusion or if seizures develop. Now, on the other side of the coin, we have hypermagnesiumism. The client in this case presents with a magnesium level that is greater than 3.0 milliequivalents per liter. Magnesium in this case is acting as a depressant. They become hypotensive. They have a decreased cardiac impulse transmission. In other words, their heart rate can be decreasing. We can have problems with conduction. There is a decrease in the deep tendon reflexes. Remember, this is the patient similar with the pregnancy-induced hypertension. We've given them too much magnesium. We know to stop it because the deep tendon reflexes have become depressed. Muscle weakness is present. They have shallow respirations and they may be flushing. This occurs usually because of renal failure, overuse of antacids, and laxative use. And so when we're thinking about these cases, we have to find out how are we going to reverse this. One of the first interventions that we should be using in the treatment of an elevated magnesium level is to discontinue any oral or IV magnesium. We also need to look at the respiratory rate, cardiac rhythm, and reflexes as we correct this problem, because we don't want to have a rebound effect occur. We should see the deep tendon reflexes start to respond. We should see improvement in blood pressure. IV calcium is an antagonist to the cardiac depressant effects, in that if we had given too much magnesium, we may be able to give calcium in order to help to bring down the magnesium. Remember, electrolytes and ions will change places within a cell. Vent support could be needed if we cannot bring this magnesium level down. So patients need to be taught how to prevent this condition from occurring. And that's by identifying where their sources of magnesium are and watching over-the-counter medication that they might be taking. Now we're going to transition out of the electrolyte section and into burns. Although we're still looking at issues of hydration, we're going to talk about some of the things you need to know when looking at a burn patient. One of the first things is, what is the emergency treatment for someone who has had a burn? And secondly, what is the care after a burn, especially regarding fluid and electrolyte and wound care? Now, if you look at Figure 1, you have what's called the Rule of 9. Don't write this down, it's in your book. Don't memorize this, it's not what the important point is. What you want to do is look at the body surface areas. If we have a child who has a truncal burn versus an adult that has a truncal burn, less of their body has been affected. The reverse would be true in the case of the head. What the Rule of 9 does is helps us determine what percentage of the body is affected by the alterations in tissue integrity, as well as the fluids and plasma that are going to be lost through this burned area. All right, so let's start to look at now at how do we assess the burn. A first-degree burn appears reddened and painful. The key piece here is there is no blistering and it is painful. First-degree burns are frequently what we get when we go to the beach at the beginning of the summer and refuse to use the sunscreen because we want some color. A second-degree burn are the students that go to the beach for spring break and want to come back with a tan in 4 days. They now have a second-degree burn because their sun exposure has caused blistering, brown and black patches, and again, it continues to be painful. The third-degree burn is a charred burn. All layers of the skin have been destroyed, and the key piece here is it is painless. You have a table in your book that also summarizes this. So what do we do for this patient who has had a burn? What are our emergency interventions for burn? First off, if the burn is being caused because of a thermal injury, in fact something is on fire, they need to stop, drop, and roll. The fire needs to be put out. In the case of a chemical burn, they would be removing the clothing or irrigating the portion of the body that was exposed to the chemical. Flush and irrigate is the treatment for a chemical burn. Something else to be thinking about when we're looking at interventions related to burn treatment is to make sure that the airway, breathing, and circulation is intact. We know that with a burn patient that they frequently develop problems 24 to 48 hours later with no burns. Their burning took place in the lung. Smoke inhalation is a burn, so we need to be looking at respiratory issues as well as just exposure of the body parts to a burn. The third thing we're going to want to do here is to keep the person warm and dry. Wound care comes into play here. If we have a person who is having an electrical burn, we need to make sure that the power is shut off before we approach that patient. This would be something that occurs during the hurricanes when electrical lines go down and can be in water and people can be electrocuted and burned. Now, implications for burns. One of the first things that we want to do is correct the fluid and electrolyte balance. There is 2 reasons why we need to get an IV going on this patient. The first and most important is to prevent hypovolemic shock. We need to have an IV access where we can infuse lactated ringers, plasma proteins, and we're going to give rapid infusion of fluids for at least the first 8 hours. The other need for the IV is for pain medication. Pain medication takes a second place. Just like in other aspects of the Nclex, pain becomes a psychosocial need. But in burn patients, we cannot medicate them for pain by a PO or intramuscular route. We need to use an IV route to ensure that the medication, in fact, is being absorbed. What else can we do? We're going to be looking at monitoring vital signs and urinary output. Here we're trying to make sure that our hydration efforts are effective, and at the same time, we're going to put this patient in reverse isolation. Now, you may think this only belongs to the patient with leukemia with neutrophil problems or decreasing white blood counts. That's not true. We have significant tissue integrity problems here, and we need to prevent them from infection. They go on reverse isolation. Again, IV pain medication will be used initially, and oftentimes it's used for the first 3 days. Again, it helps with absorption. And the last area we'll talk about on this slide is wound care. When we start to look at wound care, part of it would also be giving prophylactic tetanus if we're concerned about what is in the wound, cleaning the wound out, and then using sterile technique, whether we used a closed approach, such as applying Silvadene, or an open approach, which is using silver nitrate. This has to do with covering. Remember, we have to be cautious with fluid replacement because we have fluid shifts. And you have a wonderful table in your book that shows you about the hydration changes associated with a burn patient. Remember, we watch fluid replacement shifts up to 48 hours. Other actions that we're going to take for this burn patient is to give them a high-calorie, high-carbohydrate, high-protein diet. It is important for us to replenish and help with cell repair. They need a lot of calories. They need a lot of energy. They also need vitamins B and C for cell repair, as well as iron to help with the shifts in hemoglobin hematocrit and prevent any anemia. Prevention of complications of immobility takes on a couple different modes here. One of the things that we're going to be looking at are range of motion exercises and physical therapy. When you have a patient with a burn of, say, the arm or the leg, as the scar tissue forms, it can cause contractures. So range of motion becomes important to maintain active mobility of the joint, to limit the contractures that form from the tissue healing and tightening over the bony joints. Striker frames, circular electric beds, and turning are used to prevent any further skin breakdown, which would occur from the bed sore formation or decubituses that we might get. High-top sneakers might be used for a patient who is in bed for prolonged periods of time to prevent foot drop. The high-top sneaker keeps the foot in a plantar flexion mode, which is how we walk. But the sneakers need to be removed or you can develop bed sores on the feet inside the sneakers. Counseling is an important piece to look at. Psychosocial changes that would be associated with changes in body image is a big problem with these patients. Mirrors are removed from burn units until the patient is ready to look at the burned area, especially if it's a facial, head and neck kind of a burn. Garments are usually not allowed on the body during the initial period of the burn, and so what happens is they have light sheeting that's over top. What they will eventually do is cover them with stocking net to prevent them from scratching those areas. So pressure garments would be used in the treatment of the burn in order to prevent scarring and scratching at the skin. Now, as we think about what else we could do for these burn patients, we have to make sure this environment is a warm environment. You know, family members coming in to visit need to know to dress in loose clothing. They frequently go into tubs for debridement that have a Clorox bleach kind of solution in it for manual debridement. These are painful procedures. It's important to make sure that the patients are medicated for pain before any treatment procedure that we do. Humane care becomes important. This is the skin. The skin is sensitive, and these patients are depressed because of the changes in their body image. Now, as we move out of burn treatment, we go into another disorder that can cause fluid and electrolyte changes. Remember that the adrenal gland is concerned with mineral glucose and androgens, glucocorticoids and androgens. And so what we're doing here is we're looking at what is driving fluid and electrolyte imbalances. You will need to know the difference between Addison's disease, the need to add a hormone, or Cushing's disease, which means that you have a cushion or too much of a hormone. Secondly, you need to know what the symptoms and the treatment are for Addisonian crisis, or adrenal crises is the other name. Also, we're going to look at the medication corticosteroids, which is instrumental in the treatment of adrenal disorders in the hypofunctioning mode. In Addison's disease, the patient has a hypofunctioning adrenal gland in that they do not have enough circulating mineral and glucocorticoids. They usually present with fatigue, a decrease in blood pressure, and some weakness. They also can present with dehydration. In Addison's disease, if we do not have enough of mineral and glucocorticoids, we do not have enough circulating sodium. Sodium is what holds on to the fluid. So as the body does not have enough salt being retained, it also does not have enough fluid being retained. Patients present with an eternal tan, and they have a decreased resistance to stress. Now, we know that with these patients, their sodium level is going to be decreased, as well as their blood volume. They are potentially set up to be a shock patient. Their potassium increases, which can cause metabolic acidosis and arrhythmias. Their blood sugar in this case is decreased. Now, if you think about this patient and we try to remember how can I pick this from Cushing's, which will be the next disease, what you want to remember is these are the patients we give steroids to. If we give them too much steroid, we create other problems, the cushingoid problems. So when we think about the signs and symptoms of too much corticosteroid, if we could reverse those symptoms, we would have the signs and symptoms for Addison's disease. Now let's go on to look at some of the other problems that they can develop. Addisonian crises occurs when a patient does not have corticosteroids replaced correctly and quickly enough. They will present with a weak, rapid pulse, restlessness, weakness, nausea, vomiting, abdominal pain, severe hypoglycemia, and dehydration. Again, this is the extreme of Addisonian disease. We now have the patient in adrenal crises or Addisonian crises. What do we need to do to try and help this? Let's start first with trying to prevent this. Let's look at the first slide here, talks about what do we do to correct Addison's disease. Here we're going to look for and monitor any hypoglycemia or hyponatremia and correct them as they occur. We're going to give the patient a high protein, high carbohydrate, high sodium, but low potassium diet. Remember, in these patients, their sodium is low and their potassium is high. We are also going to teach them the importance of lifelong use of hormone replacements, such as prednisone. Now, if the patient does not respond to our interventions, they do not comply to the medication regimen, they get involved in a stress factor, or there's something going on in their life to decrease their resistance, and the steroids are not increased, such as surgery, a fracture, the death in a family, they can develop Addisonian crises. And the way we would try and treat that is to rapidly come in and administer sodium chloride IV, give them vasopressors to try and cause vasoconstriction and raise the blood pressure, and implement more steroid replacements such as hydrocortisone. We are also going to, as we do these interventions, watch their vital signs to make sure they do not over-respond and keep them on absolute bed rest. Any kind of activity stresses the adrenal gland, and if we already have a gland that is under-functioning, we don't need to do anything to cause it to have to work. Now, the flip side of this, picture the patient that we have given too much steroid to. We could actually cause ourselves Cushingoid signs and symptoms. So let's look at what does somebody look like who has Cushing's syndrome or an excess of adrenal hormones. They will frequently present with osteoporosis, and this is because there is nothing keeping the calcium in the bone. The calcium leaves the bone because we're short on mineral corticoids. They develop muscle wasting and weakness. They develop hypertension. Remember, this patient is beginning to look like they are overhydrated. They have purple skin striations and a moon face. And we've all seen the pictures of the moon face and the buffalo hump in medical surgical nursing books. They get truncal obesity. Petechiae occur because of their inability to clot, which is those micro bruises that occur on the skin, and they develop slow wound healing, slow arousal to anesthesia. What is happening with this patient? Their sodium levels are too high, and because the sodium is high, the body tries to compensate from the overactivity by holding on to extra fluids. So their blood volume increases, their blood pressure increases, but at the same token, because we're diluting out other elements, the potassium drops. If the blood sugar continues to increase, we can actually have the patient developing ketoacidosis, and they can go into a metabolic alkalosis or shock. Now, what do we do to try and intervene here? The first thing is to try and figure out ways to prevent infections from occurring and to provide the patient with some type of high protein, low carbohydrate, high potassium, low sodium, low calorie diet. These people appear overweight. Their potassium is low, so we need to replace their potassium. Their sodium is high, so we need to limit it so they do not continue to hold on to fluids. We are going to monitor their glucose level and, if necessary, put them on sliding scale regular insulin coverage, not long-acting, immediate response. If they require an adrenalectomy or a hypophysectomy, what we're going to need to do here is provide post-op care associated with abdominal flank wounds, which would be things like coughing and deep breathing, supporting the incision during movement, prevention of shock in the post-op period, finding ways to make sure that we maintain an adequate blood pressure, and hormone replacement. By removing the adrenal gland, we have now created Addison's disease. We're going to move next into another type of disorder that can cause fluctuations in blood pressure, and this is a pheochromocytoma. Pheochromocytomas have a hypersecretion of catecholamines, and we know that the catecholamines in the body cause stimulus effects, epinephrine and norepinephrine. Let's look at what the patient would look like. When a patient's developed pheochromocytoma, they present with persistent hypertension and hyperglycemia. They usually have complained to family members of a very pounding headache and visual disturbances. They may have some nausea and vomiting, weight loss, nervousness, or tremor. And in your book, they talk about 2 tests that can be used to try and identify a patient who would possibly have a pheochromocytoma. One of them is the histamine test, which is the first test that would be used. The second one is Regitine test. Here you're looking at what can we do to try and cause the blood pressure to decrease. Now let's go on and look at the implications for treatment of a pheochromocytoma. One of the things that we need to remember is that when we have a patient with a pheochromocytoma, emotional and physical stress can cause problems for them. Remember, emotions and physical stress increase the release of epinephrine and norepinephrine. We want to limit this. So we are going to put the patient on bed rest. We're also going to avoid any stimulating foods, which would be like candy bars because of caffeine. We're also going to avoid Coke, coffee, teas, anything that stimulates. Sometimes even spicy foods can be seen as a stimulant. We also are going to look at what would we be doing to try and support the diagnostic test of the VMA diet. And Nclex will ask you what food items. This is because frequently a VMA diet has to be aborted because we as nurses did not restrict the food items the patient took in that can alter the test. The food items to avoid on a VMA diet include coffee, tea, and chocolate. Also over-the-counter medications. So let's go on and see what happens if these treatments are not effective. Then we're going to have to do adrenalectomy or a medullaectomy on the patient. Again, we have a patient with a post-op incision and flank pain. In this case, because their metabolism has been increased from the release of epinephrine and norepinephrine, we need to come in and provide them with a diet that's high in calories to meet the needs for wound healing. Again, we're going to use any of that standard care associated with post-op needs. Let's look first at an alteration such as chronic obstructive pulmonary disease. What do you need to know in the Nclex about this disorder? One of the first things is, why do we use low-flow oxygen? Secondly, what medications are used, such as bronchodilators, mucolytics, corticosteroids, and anticholinergics? When we begin to look at COPD, one of the first things that we need to do is look at the assessment of the COPD patient. These patients can present as blue bloaters or pink puffers. A blue bloater is somebody with chronic bronchitis. They are usually on the heavy side and have an overproduction of sputum. A pink puffer, on the other hand, is usually your emphysemic patient. They are thin with a barreled chest and usually have an enlarged heart. These patients present with some weakness, maybe weight loss, and they both use accessory muscles for breathing, which means that they raise and lower their shoulders in an effort to try and expand the lungs more effectively. Dyspnea would be something that would occur in both patients because of the shortness of breath, as well as a cough. Their sputum usually has a tinted color to it, and the consistency can change. They need to monitor the color and consistency of their sputum. Adventitious lung sounds that you might hear could range from rales and rhonchi to wheezes or rubs, depending on the disease process. Sensorium also changes. With patients with COPD, we have an alteration in oxygenation. Anytime we change oxygenation, we change the alertness or the level of consciousness. Now, how do we evaluate a patient with COPD? What types of problems occur? One of the first examples in connection with COPD is asthma. An asthmatic patient has an obstructive disorder when they develop an episodic attack of breathlessness. They develop spasm. They have narrowing of the bronchus. Emphysemic patients have destruction in the alveolar walls. Their obstructive process is in the ability of oxygen to get from the lung into the circulatory system. Chronic bronchitis patients have chronic inflammation of the bronchi. Again, this is an irritation. It limits the ability of oxygen to get into the lung to be absorbed through the alveoli. And the last one, cystic fibrosis, which is a dysfunction of the exocrine glands. Although this is not a chronically acute obstructive disorder, these children do develop chronic obstruction of the lung. Pneumonia oftentimes will be listed in with an obstructive pulmonary disorder, but it is not chronic. Pneumonia is an acute episode, and so as much as it will cause obstruction to the ability to get oxygen to the alveolar bed, it is not a chronic condition. Let's look at what we do for someone with COPD. The first thing is to assess their ability to clear their airway. Oftentimes with congestion and thickness of secretions, they cannot keep their airway clear. We need to listen to their breath sounds. Do we hear adventitious sounds over any of the lung areas? Do we find consolidation? The next point would be to administer low flow oxygen. By doing this, we maintain their ability to breathe. Oxygen is delivered 2 to 5 liters per minute. We breathe, and our response to breathing is driven by an increasing CO2 level. With someone with COPD, their CO2 level is always high, and if we satisfy their need for oxygen by giving them too much oxygen, we will take away their drive for breathing. Encouraging fluids is another intervention that we must use. Fluids are given to keep secretions liquefied. If we have a patient that's coughing and their sputum is thick, or they have an endotracheal or tracheostomy tube and we're finding very thick, dry secretions, this would be an indication to increase their fluids. They should be taking in 6 to 8 glasses of water a day, or about 2 liters, or more if tolerated. We're also going to encourage this patient to take in small, frequent feedings. We don't want to raise the diaphragm, as would occur with a large meal, and decrease the amount of lung capacity they have any more than we want to have too much oxygen going to the stomach to digest and taking away from the other body parts. Small frequent feedings conserve energy. We also are going to use chest physical therapy on these patients: percussion, vibration, postural drainage, especially in the children with cystic fibrosis. What we want to do is try and help these children get the mucus and secretions loose off the lung and be able to expectorate those. Another thing that we might try, especially when we're looking at a post-op patient and we're trying to prevent pneumonias, is to use an incentive spirometer. An incentive spirometer is used to help with expansion of the lung, and it is designed to give the patient feedback by watching devices rise. And what you do when you use an incentive spirometer is exhale, put the device into your mouth and take a slow inhalation in. And you try to raise this monitor up to whatever the preset level would be by either the physician, nurse, or respiratory therapist. I will demonstrate. The mouthpiece goes in, and I'm going to take an inhalation and raise the yellow device that's inside, which you should be able to see on the camera. As you can see, you want a nice, slow inspiration. Incentive spirometers deal with inhalation, not expiration. It expands the lung. Pursed lip breathing is another type of respiratory device that a patient may use, and that's one that we carry ourselves. What we do with pursed lip breathing is close our mouth and exhale forcefully through our lips. This helps to empty some of the alveoli that remain distended. Would be an example. Forcefully exhaling through pursed lips. We can also use abdominal breathing, which means that instead of, as we take a deep breath in, our diaphragm rising, we actually take a deep breath in and try and expand our abdomen out in order to drop the diaphragm. So as we inhale, we lower the area where the lung can expand. What other implementations can we use with a patient with COPD? Medications are frequently used with these patients. Some of the medications include bronchodilators. Aminophylline is a bronchodilator that is used in emergency situations IV and can also be taken by mouth. Something to watch for with aminophylline is an increased heart rate and nervousness, also some nausea and vomiting. Mucolytics we talked about in safe and effective care. This was what we used for the Tylenol overdose patient. Mucolytics help to keep secretions so they can be expectorated, but they do it by liquefying secretions, not by helping with expectorating them. Those would be expectorants like cough medicines. Corticosteroids decrease inflammatory response. And the reason that we need this in this case is we do not want the lung areas to become inflamed or more narrow than they already are, the bronchus as well. So we give corticosteroids to cut down on the inflammatory process throughout the lungs. Anticholinergics are given to decrease the amount of secretions that a patient has who has excessive secretions. Anticholinergics would be something like atropine. Now, other implementations that we use obviously is teaching. When we have COPD patients, they need to understand what they need to do to protect themselves from further deterioration. One being to stop smoking. The second thing is to teach them breathing exercises. A patient can be taught to cough and deep breathe at home, especially during flu season where they are exposed to upper respiratory infections, and they don't have to have an incentive spirometer to do this. They can use a balloon, they can use a rubber glove, anything that forces you to inhale deeply, and in this case they would be exhaling into something, needing a good inhalation first. Avoiding crowds, especially during flu season or when upper respiratory infections are prominent, and getting adequate rest. We know that patients with any type of chronic illness, whether it be HIV, hepatitis, COPD, cancers, need to maintain their health. We do this by exercising regularly, sleeping regular hours, taking in enough liquids, nutritionally taking in a sound diet, and trying to decrease our stressors from the outside. These patients need to do this as well. They also want to try and limit any environmental hazards that can irritate their system. If they are allergic to and respond poorly as an asthmatic patient to pollens and stuff, they may need to move to another part of the country or try medications that will limit their response to those allergens. The next type of breathing disorder that we're going to talk about, or lung problem, is pneumonia. Pneumonia patients we have all seen both in the hospital and outside, in outside home care agencies and across the area, including the grocery lines. When we're looking at patients with pneumonia, we have patients that present with fever. They also present with leukocytosis. Leukocytosis is an increase in white counts. They have infection. We have a patient with a productive cough. Pneumonia patients' sputum is frequently rusty, green, or whitish yellow in color. It's important to get them to be able to tell you the color and consistency of their sputum. Dyspnea, or shortness of breath, would also be something we would expect to see. We have a problem that's causing a change in the lung, and thus they become short of breath. Pleuritic pain or lung pain is also something they complain of, as well as may complain that they feel like they have a fast heart rate or their chest is pounding. If we go to assess these patients, we frequently will find decreased breath sounds and consolidation. So as we're listening to the lungs, we can find an area of the lung where there is not good inhalation, exhalation sounds. We also, as we tap or percuss or have them say words as we listen, we're going to hear an area that has a deeper density. The sound will transmit through it well because of the density, but it will not be what we would expect to find on the lung. Implementations that we use for a patient with pneumonia include checking their breath sounds. In addition, we will also be monitoring their vital signs, especially their temperature and the pulse rate response. Coughing and deep breathing every 2 hours is something we want to encourage them to do to try and keep the lung as open as possible, to keep the alveoli open, to keep secretions from settling in the area where the lung is not working optimally. Chest physical therapy could be done. This will include postural drainage, chest percussion, and vibration. Incentive spirometer, which I just demonstrated, is also indicated for a pneumonia patient. We also want to encourage fluids. The patient cannot cough up and expectorate secretions if they are not adequately hydrated. Most patients with pneumonia can comfortably take in 3,000 cc's of fluid a day without putting them in a cardiac overload situation. But again, we want to be watching intake and output as we hydrate these patients. Now, what other implementations do we need to do? If the patient is unable to cough up their own secretions, it might be necessary to go in and suction them PRN or as needed. We are also going to try to support them by providing additional oxygen through nasal cannula or a mask if indicated. Very infrequently does a pneumonia patient require ventilation on a ventilator. Positioning, we need to change the position frequently, but most patients find the semi-Fowler's position eases their breathing. Again, gravity helps to drop the diaphragm, gives them a little bit more room for the lungs to expand and exchange oxygen. Bed rest is needed, and you should be able at this point to tell me bed rest is used to, correct, decrease oxygen consumption. Their lung can't take in as much oxygen, so it's real important for us not to be having them in a position where they're needing more than necessary. Put them on bed rest. Now let's talk a second about medications. We talked earlier about a mucolytic, mucomist being the example. Expectorants is something like a Robitussin. Expectorants can actually have two modes. It can be just a cough suppressant, which in fact will not allow them to expectorate. It will just get rid of the cough stimulus, or a cough suppressant that allows them to be able to expectorate. In other words, we get rid of the extra hacky cough, and the only cough left is what will produce an effective outcome. Robitussin is an example of an expectorant. Bronchodilators we've already talked about, and the example we used was aminophylline. Antibiotics that are used for pneumonia include amoxicillin and Bactrim. Now, one of the other implementations that's used for a pneumonia patient is trying to find ways to help them prevent this from occurring before. We know that once a patient has pneumonia, it's easier for them to develop it in subsequent seasons. So teaching them how to prevent the pneumonia becomes important. Avoiding crowds, taking in fluids, making sure they're resting, and staying away from people with upper respiratory infections. If in fact they feel that they are getting a cold and possibly could develop pneumonia, coughing and deep breathing is something that a patient can initiate on their own in the home environment, as well as increasing their hydration. Now we're going to move out of lung disorders at this point and move into cardiac problems. And the first problem we're going to be looking at is congenital heart abnormalities. What you need to know about changes with congenital heart disease is what are the symptoms or difference between acyanotic versus cyanotic types of congenital heart problems. What are the compensatory mechanisms observed in cyanotic heart disease? What do we need to do to meet the developmental needs of the child? And what do we do to meet the psychosocial needs of the parents? Now let's look at some of the problems associated with congenital acyanotic heart problems. Some of the symptoms that the patients present with that have acyanotic congenital heart anomalies are their color is normal, acyanotic. They have exercise intolerance. They are usually small in stature. They have failure to thrive. And remember, failure to thrive means that they are not growing and developing at a normal rate. They are thin, they are small, and on the Denver developmental scale they would be behind. They may have a heart murmur and will have frequent respiratory infections. The heart is not working optimally, there is not adequate oxygenation. So what we have is a problem with the heart and the lung, and thus they develop respiratory infections. Now, what are the types of acyanotic congenital heart anomalies? Let's look at the first one. Ventricular septal defect. It is exactly what it says. We have an abnormal opening between the right and the left ventricle that produces a large, loud, harsh murmur. We have atrial septal defect, an opening between the right and left atrium. In this case, the patient may go or client may go without symptoms. It's in the atrium. Patent ductus arteriosus is a disorder where the pulmonary artery is connected to the aorta, and which should have closed at birth, but it remains open. Congestion occurs, there is a murmur, a wide pulse pressure, and an increased heart rate. In this case, we have blood getting out into the system that has not been adequately oxygenated because of the opening. Coarctation of the aorta is the fourth type, and here we have coarctation meaning narrowing of the aorta, which creates pressure as the blood leaves the heart, but as it gets away from the narrowed section of the aorta, we have a low pressure, and so distal to the area, the patients have poor pressure or poor perfusion. Pulmonic stenosis, which is a narrowing of the pulmonic artery, which does result in a murmur, as well as aortic stenosis, which would be narrowing of the aorta, causing also a murmur. How do we assess this child that would have cyanotic heart disease? How would they appear different from the ones that are acyanotic? The first thing that you should identify is that the patient will be bluish. So let's look at some of the other signs. Cyanosis being prominent. They are cyanotic. They have clubbing of their fingers. We've seen this in end-stage respiratory and cardiac disease, and this is where the fingers take on an abnormal angling, the fingernail itself. Seizures. This comes from hypoxia. Prior to seizures, they may present with a change in level of consciousness. Now, in an infant, we're not looking at their ability to carry on a conversation, but are they restless, or do they seem lethargic? Marked exercise intolerance. These are children that will squat or pull their legs and limbs up to the trunk to try and decrease the hypoxia that occurs after exercise. They also usually have difficulty eating. Remember, we talked earlier with the pulmonary patients about the need for small frequent feedings because of oxygenation. It's the same case here. Eating a lot causes fatigue in these patients. It takes energy to suck and it takes energy to digest, both requiring oxygenated blood. Now, what do we do as far as assessing this a little further? What do we see these patients present with in addition? Small stature. Again, failure to thrive. They have a characteristic murmur, and we will talk about some of those. And lastly, frequent respiratory infections, again showing the connection between the cardiac and pulmonary system. Now, what are the types of cyanotic congenital heart anomalies? Tetralogy of Fallot is a disorder that occurs from 4 defects, all requiring surgery. Ventricular septal defect, an opening between the ventricle, pulmonic stenosis, a narrowing of the pulmonic artery, overriding aorta, and right ventricular hypertrophy. These patients do present with a harsh murmur and are usually identified as having the problem at birth. Transposition of the great vessels occurs with genetic abnormalities, and here you would have the pulmonary artery leaves the left ventricle and the aorta leaves the right. Blood is not oxygenated and surgery is definitely indicated. Truncus arteriosus, which occurs when there is no division of the pulmonary artery and aorta and there is only one vessel for both ventricles. Surgery is definitely indicated in this case and a murmur would be present. Total anomalous venous return is where there's an absence of direct communication between the pulmonary vein and the left atrium. What does a child do to compensate for this problem? Analysis of the compensatory mechanisms associated with these disorders include tachycardia, polycythemia, and remember this is where the body produces an excess amount of red blood cells in order to try and increase the oxygen carry capacity of the blood, posturing or squatting into the knee-chest position. Now, what is indicated to try and correct these anomalies? The first thing is to try and prevent them. Moms that go through prenatal care, decrease alcohol consumption, would get off drugs, would decrease the risk of these anomalies developing. The other thing that we want to be able to do is to try and recognize the symptoms early in the disease process. Is the child having a decreased weight? Are they a poor feeder? What is their coloring? Are they cyanotic? Are they irritable? We also want to monitor their vital signs and heart rhythms. Medications are indicated. Digoxin is used to increase the pumping action of the heart. Iron preparations are used to try and boost the oxygen carrying capacity. Diuretics would be used to prevent any congestive heart failure from poor cardiac output, and potassium is indicated because of the diuretic use. We're also going to change their feeding pattern. We're going to go to small amounts every 2 hours, give them a large nipple opening on their bottle, both trying to decrease the oxygen that they're using in order to eat. We're also going to give them a low sodium diet and increase the potassium that would be in their formulas. We're going to provide support and education for the parents. It's a very scary feeling to be told that your child is going to require cardiac surgery and to look at a child that's not developing normally. Let's move on and look at an adult disorder, or predominantly adult disorder, congestive heart failure. Again, any of these children with the congenital heart anomalies could develop congestive heart failure, but primarily this occurs in the adult population. Congestive heart failure, what do you need to know? First, we need to know what the symptoms of right versus left-sided failure are. Secondly, frequently tested are the medications, cardiac glycosides, digoxin in particular, and diuretics. And what kind of lifestyle or dietary changes need to occur? The first thing that we need to be able to do is be able to assess the difference between left-sided and right-sided failure. Left-sided failure is a pulmonary component. The blood cannot get out of the heart, so it backs up into the lung. The patient presents with dyspnea or orthopnea. Remember, orthopnea is where they ask to be raised on a pillow and then into an upright position, especially during sleep. Cough is present. We are flooding the lung with fluid. It's like drowning it, so the patients do develop a cough. Pulmonary edema will be present. They will have rales and pink-tinged sputum. They will also develop some weakness. Again, we're developing hypoxia. The lung is not getting the oxygenated oxygen into the circulatory system, and thus we will also see changes in metal status occurring because of this anoxia or hypoxia. When we look at lab value changes, we might see an increase in BUN. Remember, this is a patient that's having problems with hydration. The body thinks that it's underhydrated because it's not circulating through the circulatory system. It's trapped in the lungs. So the BUN starts to climb just like they were hypovolemic. They are not in turn hypovolemic. The fluid just is not where it belongs. We need to shift it. So what do we do to try and determine the difference between the right side and left-sided patient? Assessment for a right-sided congestive heart failure patient usually looks at symptoms that occur in the periphery of the body, in the extremities. The blood cannot get back to the heart, so it invades and swells up the extremities, so we get dependent edema. The liver gets enlarged or engorged, and this is again because of congestion in the periphery. They develop abdominal pain because of the engorgement of the abdominal organs, with nausea and some bloating. The extremities become cool because the blood becomes trapped there. The more we back up the blood as far as trying to exit or get back into the heart, the more we have blood that gets trapped into the extremities. They develop a cool temperature. They aren't getting rich blood. They are not getting oxygenated blood. Now, as we start to think about what do we do to treat the patient with congestive heart failure, of course we want to treat the patient with right-sided failure aggressively to prevent left-sided failure from occurring. So let's look at what we could do initially. Implementation or treatments for congestive heart failure include actions to improve the pumping and exiting of fluid from the body. We are going to give them digoxin, cardiac glucosides. We are going to give them diuretics like Lasix or aldactone. Remember, we need to know which diuretics are potassium sparing, which would be aldactone, and which ones are potassium losing, such as Lasix, so that we can intervene and replace potassium. We're going to put these patients on a low sodium, low calorie, low residue diet. We are also going to add to their treatment oxygen therapy. When they are developing left-sided heart failure, their oxygenation ability has been compromised. Oxygen therapy would be indicated. Not only are we going to weigh them in the hospital, but these patients are going to learn to weigh themselves at home. And as they get visits from home care nurses, they will be looking at their clients' changes in body weight. A small change in weight can be a significant retention of body fluid. And lastly, we need to teach them about their medications and their diet. One of the things we in particular would want them to be aware of is when would they see signs of digoxin toxicity, and what do these signs look like. They're not going to know if they have not been taught how to take their pulse that a dropping pulse rate could be an indication of dig toxicity. But they should be told that nausea and vomiting and yellowing vision would be something that needs to be reported to their physician. They also need to understand that the dose of digoxin they may have gotten during an acute episode as a startup new drug is going to be larger than their maintenance dose of digoxin. Now, the next heart disease that we're going to look at is angina pectoris. We've already talked about myocardial infarctions, but now what we're going to do is look at the issues surrounding angina. Remember that with an MI, their pain was not relieved. With angina, the chest pain is associated with stress, exertion, and anxiety, but it is relieved by the use of rest and or nitroglycerin. Remember that they take nitroglycerin every 5 minutes to a total of 3 tablets. If that pain has not been relieved, at that point in time they need to activate the EMS system and dial 911. How do we treat the patient presenting with angina? The first thing that we're going to do is administer anti-anginal medications, such as nitroglycerin. We are probably going to start them on calcium channel blockers, such as Procardia. We also are going to institute aspirin therapy to try and help thin or prevent thrombus formation from increasing. We're also going to encourage them to make some lifestyle changes. We're going to be having them look at diet, stress, and exercise. Some of the dietary changes that they might make would include a decrease in fat, decrease in calorie, and decrease in cholesterol usually. Now, in addition to trying to treat this patient medically and with diet and behavioral changes, we also may institute a treatment procedure called PTCA. PTCA stands for percutaneous transluminal coronary angioplasty. It's a method of looking at the vessel and compressing the plaque against the wall through the inflation of a balloon. Complications that can occur associated with this treatment are bleeding, hypotension, a reaction to the dye that is injected, hypokalemia because diuretic therapy is sometimes used during this treatment, and dysrhythmias. Dysrhythmias occur because we have stuck an odd wire into the heart itself. It irritates the foci, and in addition, as we open up and perfuse an area of the heart that has not gotten oxygen before, it may develop ectopy or excitement because of the oxygenation that it's getting. If the PTCA does not work, or the angioplasty does not cause the vessel to remain open, it may be necessary to go in and do a CABG, a coronary artery bypass graft. And when we do a coronary artery bypass graft, what we're attempting to do is graft coronary arteries that will bypass the connector or the blockage that's present. We're going to take a vessel out of the leg or the breast area and transplant it into the area where the vessel is occluded, almost like making a bridge around a bridge that has collapsed. What might we see as complications associated with this serious intensive care requiring surgical procedure? The first thing is bleeding. They are given anticoagulants because the heart is stopped during this procedure, and in order to prevent clots from forming, the blood is anticoagulated. We also can see major changes in blood pressure, both increase and decrease. We attempt to control this patient by using medications to keep the blood perfusing well. If in fact we were to give too much dopamine, we could in fact cause a hypertensive crisis, so we need to monitor the blood pressure. Fluid and electrolytes become an important issue and must remain balanced. Sometimes the potassium can get out of line, magnesium as well, and we've talked about the indications that they, as well as sodium and particularly calcium, can have on conduction. Cerebral perfusion can be another complication if it becomes that the heart can't pump effectively, or during the surgery, oxygenation is impaired. At this point, the brain no longer is getting enough oxygenated blood, and a stroke can occur. Patients go into this surgery knowing that a stroke could be a complication to, in fact, correcting their heart disease. Now, these patients come out of surgery with some other types of devices attached to them, and they need to know about that beforehand. They may have a chest tube, and I did show you what a pleurovac looked like earlier in the previous tape, and we'll discuss it again in the next one. They also may be on a ventilator for sometimes a few hours and sometimes longer. We also look at the need for pacing. If in fact the heart cannot come back into a normal pacing rhythm, it may be necessary for a short period of time to use an external pacemaker. Something that you want to watch for in this patient is what's called cardiac tamponade. Cardiac tamponade is an emergency situation that occurs when blood is trapped in the pericardial lining, and remember that's the sac that surrounds the chambers of the heart and causes constriction of the heart itself. Too much constriction will stop the heart. So you need to observe heart sounds and look for a harsh rub or murmur. This ends this tape. We will start up the next tape looking at the assessment of arterial and venous peripheral vascular diseases. Thank you very much. Welcome to Physiologic Adaptation Part 3. In this section we're going to be looking at the assessment of arterial and venous peripheral vascular disease and the interventions, as well as cancer, and this will finish this unit. Let's look first at the assessment of arterial peripheral vascular disease. In this condition, the patient presents with rubor skin. The skin is cool, shiny, and ulcers can be forming. If left untreated or oxygen too depleted over time, gangrene can set in. Intermittent claudication is also a symptom frequently complained about by clients or patients with arterial peripheral vascular disease. Remember, in this condition, blood is not getting to the extremity in order to get oxygen to the tissue. We have impaired sensation, numbness and tingling, and decreased peripheral pulses, poor perfusion into the area. What do we do for someone who presents with arterial peripheral vascular disease? One of the first things that we want to look at is assessing the peripheral pulses. We want to provide good skin care, foot care in particular. We need to encourage them to stop smoking. Smoking is a vasoconstrictor, and it alters oxygen carrying capacity of the blood. They do not need to do anything that further impairs oxygen getting to the tissues. Regular exercise is encouraged. This helps with perfusion into the area as well as the pumping mechanism to get the blood out. Medications may be ordered. An example would be vasodilators, thus dilating the blood vessel and hoping to get more oxygen to the tissue, as well as anticoagulants, preventing the blood from becoming viscous, thick, and thrombophlebitis resulting. Another thing that we would want to look at here is positioning of this patient. If we are having difficulty getting blood into an area of the leg or arm, we want to keep it in a dependent position. Keeping this extremity down will help oxygenated blood get into the area and lessen the pain. But there should not be any pressure on any pulse points, such as the back of the knee. Now let's look at as far as what we would do to assess for venous peripheral vascular disease. In these patients, we're going to see cool brown skin. We are also going to see some edema and a normal or decreased pulse. The difference being here is oxygenated blood can get into this tissue, but congestion prevents waste products from being carried away from the tissue. The area becomes engorged because the blood is trapped there. We also can find patients presenting with a positive Hohmann sign. Remember that the Hohmann sign is pain that is inflicted when you dorsiflex the foot up towards the chin. What we would do with these patients is try and help them alleviate their pain by elevating the extremity. Again, we have blood that is trapped in the extremity. By elevating it, gravity will help it drain out, decrease the edema, and hopefully decrease the pain and swelling. Now we're going to look a little bit at other interventions that we can use for somebody presenting with venous peripheral vascular disease. One of the first things that we're going to do again is to assess or monitor the pulses. It's important to know what the status of the pulses are. Once the pulses are obliterated, we have more extensive disease than when the pulses are still present in this condition. We're going to encourage these patients to wear elastic stockings. Elastic stockings or TED hose have been known to help with return of blood to the heart, increase venous return. Medications are also used in this condition, but instead of vasodilators, we are simply going to use anticoagulants. Again, we want to prevent the congested blood from becoming clotted and occluding off the vessels. We talked earlier about elevating the legs to reduce pain. Again, this gives it an opportunity to enhance venous return and decrease swelling. Warm, moist soaks may be used. This alleviates pain, helps with the exit of fluid, but you have to notice this says warm. When we have impaired circulation to an extremity, frequently we will also have a decreased temperature sensation. We don't want to burn these extremities. Let's look now at another disease that affects the cardiovascular system, and that's hypertension. How does someone appear that has hypertension? Who develops hypertension? We know the warning signs. Patients that are under high stress, patients that smoke, have high fat in their diet, are obese, don't exercise, would all be at risk of developing hypertension. But what do they appear like? We know that it is a silent disease, oftentimes presenting with no symptoms. But some patients do present with some headache. Also, nausea and vomiting. Dizziness may be present. Blurred vision. Retinal hemorrhages. They may begin to develop anginal pain because we know that hypertension interferes with circulation through the cardiac cycle. Anginal pain will develop because of impaired circulation. Again, these patients may be asymptomatic, and we need to remind patients being treated for hypertension that they do not always have symptoms of the disease. Patients with renal failure, patients that have hypertension may develop renal failure as well as dyspnea, and may develop congestive heart failure in the left-sided form that we talked about previously. The right-sided form would present as edema of the extremities. So again, untreated hypertension can lead to renal failure, right and left heart failure. What do we do to implement some actions here to prevent hypertension from becoming disastrous? One of the most frequent interventions used to treat hypertension is the use of medications, antihypertensive medications. An example of these would be Lopressor as a beta blocker. Beta blockers have a complication of pulmonary complications. So what we need to do is make sure that our patients do not have a pulmonary problem before being started on a beta blocker. Corguard is also a beta blocker and can be used to try and reduce the blood pressure. Serpacil is a sympathometic. It is used to help reduce blood pressure as well as Aldomet. But the difference with Aldomet versus Serpacil is that Aldomet is taken at night because it has a side effect of drowsiness. This would be a good question to be asked on the Nclex. Minipress is an alpha blocker. It is used in conjunction sometimes with another drug in order to keep blood pressure down. But its major side effect, especially when it is first started, is syncope. So if we were asking a question about mini-press, you would need to make sure that you were assessing your patient for syncope. The next intervention we're going to use for hypertensive patients is to get them to reduce their weight. Frequently they are overweight, their diet is high in fat, calories, and cholesterol, and thus we try to do teaching to change that. Another type of lifestyle change that we might do is encouraging exercise, encouraging stress reduction techniques, and also trying to maintain a normal fluctuation between sleep and rest. Teaching the patient about medications and the diet allows them to take responsibility for this disease. Remember, it does not have symptoms, so by them understanding what actions these drugs and the diet changes take place, they can look for subtleties and where they maybe are feeling better. But remember, a low-sodium diet would be added to these patients to try and prevent the accumulation of fluid. So in addition to fat, cholesterol, and calories, we would also reduce the salt. Now we're going to move from hypertension into anemia. Anemia is a disorder that affects the ability of the body to circulate oxygen. Hemoglobin carries oxygen, and with anemia we do not have that capability. What does someone look like who has anemia? Usually they present with palpitations. The heart tries to compensate for the lack of circulating oxygen by pumping more quickly. Then from this, they develop shortness of breath. Because when our heart rate increases, so does our respiratory rate, and we breathe more shallowly. They may develop diaphoresis. The heart is working hard, the lungs are working hard, and they begin to sweat. They also can complain of chronic fatigue. Chronic fatigue results from the inability to get oxygen and iron to the body parts during exercise. Sensitivity to cold is also a hallmark symptom, and frequently when a client presents into an outpatient area, and they may say, "I'm tired and I'm so cold." And as we get the hemoglobin and hematocrit results back, we in fact can see anemia. Anemia symptoms can appear in a mild, moderate, or severe form, and we really want to be astute as healthcare providers in picking up the mild and moderate symptoms before it becomes severe. Some of the severe signs and symptoms are exhaustion, headache, and cardiac compromise or complaint. This is where the patient's blood counts drop so low that the heart is no longer getting enough oxygen and in fact start to develop anginal pain as a warning signal that it needs more oxygen. The coronary arteries are fine, but there's not enough oxygen getting to the heart muscle. Symptoms for anemia usually do not become severe or prominent until a patient has a hematocrit count of a hemoglobin count of less than 10. So if we see a hemoglobin count less than 10, we may not be transfusing yet, but we need to be observing for signs and symptoms of anemia. Let's look at some of the implementations for anemia. The first thing that we want to do is try and identify the cause. Are they bleeding? Do they have a cancer? Is there something wrong with the monetary standards in their house that doesn't allow them to be able to buy foods that are rich in iron or healthy type foods? Are they getting frequent rest periods? Let's look at the diet. A diet for someone with anemia needs to be high in protein, high in iron, and high in vitamins. We need to get iron into the blood. That is carried there by various vitamins, such as vitamin C. So in addition to giving supplemental iron by vitamin, we might encourage the patient to eat green leafy vegetables, organ meats, or dry fruits. And taking these substances with a vitamin C source will also enhance its absorption. The rest periods allow the body to respond and repair, and by limiting the amount of activity, we don't use the oxygen that's there until we've built it back up again. Protection from infection is another key point. Infection would further stress the body. We need oxygen to fight off infection. If the hemoglobin and hematocrit counts are low, we don't have the oxygen carrying capacity to be able to fight off infection. Another type of anemia that we see frequently in this country is sickle cell anemia. Sickle cell anemia differs a little bit from hemolytic anemia, like we were discussing, in that the patients present with pain. Sickle cell anemia is a sickled cell that is incapable of carrying oxygen. It usually presents in the African American population and can be found on genetic testing. In addition to pain, they often have swelling at their joints and will develop some fever. Fever usually goes with swelling. Jaundice may occur because the body is breaking down cells prematurely and bombarding the system with these broken down cells, thus causing jaundice to develop. Because we do not have enough circulating oxygen, again, they develop tachycardia and sometimes cardiac murmurs. The heart begins to try and compensate for the incapable cells of getting oxygen, and so it pumps harder and faster. Sickle cell anemia patients may have anemia levels between the level of have a hemoglobin level between the levels of 7 to 10. What do we do to try and help a patient presenting with sickle cell anemia? One of the first things we need to look at is what is bringing on the complaints. Sickle cell anemia can be present with no signs or symptoms until the body experiences a stress, such as infection. This can bring on a crisis. At this point in time, we need to be checking, do the joints have pain and swelling? If so, and they're uncomfortable, we need to treat them with pain medication. A hallmark treatment for sickle cell anemia is to encourage fluids. We want to decrease the viscosity of the blood. In addition to fluids, we're also going to administer extra oxygen either by nasal cannula or a mask. We want to try and increase the oxygen that's circulating, decrease the viscosity of the blood. In treating the pain, it becomes harmful to continually give IM injections to a patient who is needing pain medication every 3 to 4 hours. So frequently a sickle cell anemia patient during crises will go on a PCA pump, patient-controlled analgesia. They can deliver a preset amount of medication as needed over time and may in fact be getting a continuous drip as well of a drug such as morphine. Now, if we move out of sickle cell anemia, we start to move into hemophilia. Hemophilia is another blood disorder that can result in bruising, pain, and prolonged bleeding. These patients present very pale. They are lacking a coag factor 8. They are unable at times of clotting blood. And so when they bang or bruise themselves, they may bleed into that joint. What we do as far as trying to implement to help someone with hemophilia is to put them on bed rest and to administer plasma or factor 8. Analgesics are also used, but in this case we would not want to elicit the use of aspirin. Aspirin is an anticoagulant and would further encourage more bleeding. We also want to teach them about how to change their lifestyle. They should never receive IM injections, and when an extremity becomes bumped or bruised, they need to get off of it, elevate it, and frequently ice it to try and slow down the bleeding that would occur. This ends the area on looking at blood type-driven disorders. Now we're going to move into cancer. What type of information do you need to know about cancer? When we begin to look at cancer, we want to look at what is the nursing care in particular around radiotherapy, both internal and external. What are the difference? What makes the patient radioactive or not? We also need to look at and understand the action of some general chemotherapeutic drugs. We're going to look at how we look at side effects for these patients and help them feel better during their disease process. How does a patient appear that has cancer? We know some of the patient's signs and symptoms. We see them on the television. We stress them to the public. They need to be noticing any changes in bowel or bladder habits or a sore that does not heal. We know that skin cancers can present with a sore that seems to change in texture and configuration. There can be unusual bleeding. This could be rectal, it could be in the mouth, and it can be through the skin. Thickening or a lump that forms would be a good example of breast cancer, and any lumps that form and are hard and isolated need to be examined by a physician. Ingestion or difficulty swallowing would be a sign or symptom of a GI or a throat-type cancer. Obvious changes in a wart or mole would be another indication to evaluate skin cancer for, and a nagging cough or hoarseness can be an early sign of laryngeal or lung cancer. Remember, Nclex is looking at wellness and prevention. It's important for you to identify ways that we can teach the public to prevent the development of cancer and to identify its early warning signs so we can treat them quickly and effectively. One of the treatment options that we can use for cancer is external radiation therapy or cobalt. Let's look at how we administer that type of treatment. With external radiation therapy or cobalt, there's going to be markings put on the skin. This allows the X-ray camera to zoom in on the organ or part of the body that needs to be radiated. These markings need to remain on the skin and not be washed off. Because we are delivering high radiation rays through the skin itself, the patient is advised to avoid the use of creams and lotions. These have metals in them and can cause burning. The radiation itself destroys the skin enough. We don't need to enhance that. We're going to check for redness or cracking of the skin, and oftentimes physicians will encourage the patient to use a corticosteroid or lotion between treatments, but this must be removed before they go for the next radiation treatment. Patients are encouraged to wear cotton clothing. We know that polyesters can stick. Polyesters trap heat. Cotton absorbs moisture and allows the exchange of heat and cool through the skin. Cotton clothing is advisable. We also are going to administer antiemetics. Depending on the part of the body that the radiation is being zapped at, may cause the patient to become nauseous. We want to control nausea and vomiting with antiemetics in order to encourage optimal nutrition. Now, what's different between external radiation and internal radiation? Internal radiation is a sealed source, radium or gold, which is implanted into a cavity in order to provide direct radiation to an area. A lead container or long-handled forceps are in the room, so if in fact this would fall out, you have a way to pick up and trap it in a lead container. While the patient has the implant in, we have to save all dressings and bed linens. This is not because they are radioactive, but because we are concerned with whether it would fall out. If it fell out and we could not locate it because we discarded sheets, we now have a radioactive substance in the hospital laundry. Urine and feces are not radioactive. This differs from the unsealed source. Urine and feces do not need to be saved or handled specially because they are not radioactive. But because we have an implanted source in a cavity, you do not want to stand in line of the patient so that that radiation source can emit to you as well. You must stand to the sides. You also want to limit the amount of exposure that you have to that patient. The patient is going to remain on bed rest as long as the device is in place. This is to ensure that it is not lost. We may use catheterizations if we don't want to lose it through urination, and we may give enemas so that they don't bear down and force it out. Now let's look at the difference between a sealed source, which is in one cavity, and an unsealed source, which can be given like iodine that would have a systemic effect. All body fluids are considered contaminated. This includes urine, feces, and sweat. The greatest danger of contamination to the public or to the nurses taking care of the patient or their families is during the first 24 to 96 hours. Thus, the patient is placed in a private room, and a dosimeter is worn by any individual entering the room to take care of the patient. Visitors are limited. This means we need to deal with issues of isolation. The patient is alone in the room, and we need to find ways to help them not feel so isolated, some type of diversional activity, books, TV, or radio. The nurse needs to significantly limit the amount of time she spends or he spends in the room. Mouth care is important. We know that with any type of treatment for cancer, the potential for mouth sores is great. As we develop mouth sores, we develop malnutrition because it's painful to eat or drink. And with malnutrition, we develop further weight loss. We can't afford to compromise these patients any further. They need to use saline rinses and a soft toothbrush and avoid any really hot or cold liquids. Hair care would be important as well. Some of these patients that are receiving internal radiation therapy also have received chemotherapy, and they may be losing their hair, or their hair is going to dry out. This is an issue of self-esteem, and it's important for the patients to feel, or the client to feel, positive about the way they look. Bright scarves or wigs can be used if the hair is thinning. Skin care is important. We don't want the skin to break down. We need to encourage them to try and change position, especially in the case of the internal radiation implant sealed source where they are confined to bed. We need to watch the skin and manage it. Pregnant nurses should not be taking care of patients with radiation implants, and the staff should be rotated. Now let's talk a little bit about some of the other issues surrounding the internal and unsealed source of radiation. We need to discuss with these patients the alterations in their body image. Oftentimes, different department stores will send people in to do makeup clinics and offer support to them as far as clothing and color. Anything that can help a person feel better about themselves, and this is not just women, it also includes men, is helpful. We're also going to administer medications. Again, if the patient is complaining of nausea and vomiting, we need to give them an antiemetic before they begin to vomit. If they're experiencing pain, we need to give them some form of analgesic, be it Tylenol or Dilaudid, whatever the level of pain is that they're experiencing and the stage of cancer that they're at. Antidepressants might be indicated. Cancer is a terminal illness frequently, and it's a very devastating effect for the patient to see their life possibly go before their eyes. Antidepressants can help the patient not only deal with the disease, but move forward, and it may, in fact, enhance the outcome of the treatments they're receiving in a positive way. Corticosteroids would be used to try and decrease the inflammation where the site of the cancer is at and its surrounding tissue. Again, if we are administering corticosteroids, we need to make sure we observe for those side effects that we discussed earlier. Nutritionally, we need to offer them small, frequent feedings. Eating frequently anything that they would enjoy eating is better than forcing a large meal at any one time of the day. We all have had times where we weren't feeling well and have someone serve us a large plate of food, and instead of picking at small amounts, we in fact eat nothing. Take them in small amounts frequently. If they can't tolerate any oral feedings at some time period, then we need to institute TPN, or total parental nutrition by vein. Encouraging them to participate in decision making allows them to feel part of the treatment plan, and not that the care is to be directing at them, but with them. They need to make decisions, and we need to respect those decisions. Now let's talk for 1 minute about general care of a patient with cancer. We're getting ready to move into leukemia, but these implications are not just centering around leukemia. It could be any form of cancer. Skin becomes important. We need to keep the skin intact. We feel better when our skin looks good. We also don't need the pain that's associated with decubitus. The mouth needs to be maintained. Rinses, not alcohol rinses like we would find with traditionally sold department store or drugstore mouthwashes. The hair. Let's find something to do where the person can look in the mirror and actually feel like they look pretty or handsome. Nutrition. We talked about small, frequent feedings so the stomach is not distended, so the food can stay down and be digested and they can eat. Activity and rest. I love to walk through a mall and see the walkers for the American Cancer Society there with their partners, encouraging people with cancer treatment, and you can identify them when they're getting radiation or chemo from the hair loss. Walking. Exercise is important. It releases endorphins. It keeps us cardiovascularly and pulmonarily fit. And lastly, psych. We need to be able to intervene and help them make choices about hospice and where their life needs to go and what their family needs might be. So often, nurses focus only on the pain management as far as the psych is concerned, and they don't look at the emotional and outside needs to get them home and the environment that they're comfortable in. Now let's talk a minute about leukemia. What do you need to know about leukemia? The Nclex is not going to ask you to be an oncology certified nurse and answer high-level questions related to cancer, but it's important to understand some basic information about a few of the cancers. When we look at leukemia, one of the most frequently asked questions has to do with bone marrow aspiration procedures and the nursing care around it. Remember that with a bone marrow aspiration, we need informed consent. It's an invasive procedure. We are either going in through the iliac crest or the sternum to take off a piece of bone sampling, and from that, because it's invasive, we have to get a permit from someone. It's also painful. It would be nice if physicians would remember, and if not, if we would remind them to pre-medicate these patients for pain, or at least give them something for their anxiety. The thought of somebody scraping bone off of my iliac crest sounds painful even without the procedure being done. Local anesthetics can be used, and this, you have to remember, is a sterile procedure. If the physician breaks sterile technique, you need to stop him and get another tray. Complications associated with a bone marrow aspiration include osteomyelitis, which is the infection in the bone. Makes sense. We're putting a needle into it. Bleeding, we're doing a scraping of a bony area that also is rich in red blood cells and have gone through tissue to get there. And puncture of an organ surrounding it, if in fact we would miss the area we were trying to get the bone marrow sampling from. Now that we talked about a diagnostic test that would be used for leukemia, let's backtrack and look at what the signs and symptoms an individual might have presented with in order to lead us to needing to do this procedure. When we're looking at assessment of leukemia, we're looking at ulcerations in the mouth, anemia, which would be a decreased hemoglobin hematocrit count, as well as the differential shift, fatigue, weakness, and pallor. Doesn't sound very different to me than the symptoms that we would see with anemia. So it's important for us to look at family history, other patient complaints, and associated problems. What do we do to treat a patient that has leukemia? What becomes our goals? And these are not set in priority order, but let's start with monitoring for bleeding. If we have anemia and the leukemia is affecting the clotting ability of the blood, there's a potential for bleeding. We need to watch the gum, teeth, mouth, and skin tissue, as well as urine and stool for any form of bleeding. We also want to watch the patient for infection. A leukemic patient has alterations in their white blood count. Neutrophil counts can drop very low during chemotherapy and radiation, particularly chemotherapy. And when the neutrophils drop too low, these patients are at increased risk for developing infections that they would not get if they were not compromised. So we need to monitor for infections and treat them quickly. Good mouth care becomes important, and we talked about this just in general as far as any cancer patient is concerned. Make sure that they're using the water rinses or at most just salt water. High calorie, high vitamin diets become important. Cancer patients' metabolic rate increases to try and compensate for the lack of circulating normal cells. They burn off and lose weight easily. They also have impaired skin integrity. So by increasing the calories and vitamins in their diet, we can hopefully promote health over a longer period of time. If in fact the white count starts to drop and we get a shift in neutrophils, the patient may be placed on neutropenic or reverse isolation. This is not where we're preventing the patient from giving us their cancer. We actually are preventing us from giving the patient something we might be carrying. It's important for the door to remain closed, to use scrupulous hand-washing techniques, and wear a gown and mask with contact with the patient. Medications are a treatment plan for leukemia and can include chemotherapy and most oftentimes associated antiemetics prior to the chemotherapy being instilled. Remember, the chemotherapy causes severe nausea and vomiting, and by starting the patient off on antiemetics, we can eliminate this horrible side effect and increase the patient's comfort while they get the chemotherapeutic agent. Nurses that administer chemotherapy are certified nurses. They know the background of the drugs, and they are responsible for correct protocol in the administration. Two people check the chemotherapy before it's administered, and it's checked against the chart as well. It's important that we make sure we do not give excessive doses or the wrong chemotherapeutic agent to a patient, and this has occurred in the news. Bone marrow transplants would be another indication or treatment that could be used for a patient with leukemia, and these patients would also be in a critical care area while they receive their bone marrow transplant. One of the most important things for the nurse to remember would be prevention, getting patients and clients as a preventative measure to protect themselves from the sun, to be able to recognize small, waxy nodules on sun-exposed skin, to look for the nodule, crust, or ulcerations that occur in an area that's not healing. Basal cell carcinoma is the most common type of carcinoma of the skin, and it rarely metastasizes. That's the good news. Now let's look at squamous cell carcinoma and how it compares to basal cell carcinoma. Squamous cell carcinoma is a rough, thick, scaly tumor on the arms or face, and this one in fact may metastasize to other body systems, not just other parts of the skin. The worst type of skin cancer would be the malignant melanoma. Let's look at how this differs. Circular lesions, variegated color on the trunk or the legs with irregular edges. These are wounds that are larger and more unusual in appearance. It is usually seen in 20 to 45-year-olds that are fair complected, blue eyes, with red or blonde hair and freckles. Again, this is the most lethal type of skin cancer. What do we do to try and treat the patient presenting with a malignant melanoma? What the nurse wants to do first is to try and encourage the patient to avoid exposure to the sun between the hours of 10 and 3. We want to encourage the use of sunscreen with high FPS factors. They should be wearing a hat anytime they are out of doors and checking their skin surfaces monthly for any changes or new skin lesions. Medications such as chemotherapeutic agents will be used to treat malignant melanoma, but again, this is frequently a lethal or terminal type of cancer. They also need to report to the physician any changes again in the color or shape of any moles so that they can pick up any new or reoccurring skin lesions. Now we're going to move out of skin cancer and look at intracranial tumors. Earlier in this discussion we talked about increased intracranial pressure as well as head trauma. What we're talking about here are lesions that are growing within the brain that will actually present very similarly. Let's look first at what we need to know about an intracranial tumor. One of the frequently tested questions on the Nclex is the positioning after supra or infratentorial surgery. Now with intracranial tumors, let's first start by looking at what we would be assessing in these individuals. One of the first things we're going to assess for is their motor deficit. Depending on where the tumor is growing will cause changes in their motor skills and sometimes in speech as well. Frontal lobe tumors, the front of our forehead, presents with personality or behavior changes, speech. The parietal area, the top of the head, if you think of a king or a queen as being very proud, the parietal area looks at proprioception. That's our coordination. The temporal area, the sides of our head, deal with hearing, which is easy to remember because of the ears, and part of our speech. Occipital, the back of the head at the base, is where our vision is originated. Motor deficits need to be evaluated. Hearing and vision changes or disturbances need to be documented, as well as any dizziness or paresthesia. Here we're looking at the ability or the cerebellar function of the patient. Seizures may be noted. This would be generated from the motor cortex. Personality disturbances, again from the frontal lobe, as well as changes in their level of consciousness. Nausea and vomiting is also a frequent complaint of individuals presenting with an intracranial tumor, especially children, and the vomiting is frequently projectile in nature. What do we do for the person who is presented with an intracranial tumor? Remember that it's important to get a baseline developed and documented assessment before any interventions are started so that we can pick up side effects to treatments that might be causing further deterioration instead of improvement in the condition. We need a baseline. Implementations associated with intracranial tumors include maintaining a patent airway and elevating the head 30 to 45 degrees. This elevation would take place after supratentorial surgery in the presence of increased intracranial pressure or if the patient for whatever reason was having some respiratory difficulty. But let's go back in a minute and talk about the elevation in relationship to supratentorial surgery. If you can picture on my head, supratentorial surgery takes place at the top of our head. And so positioning in the bed, if we were to lay back on my back, I am not going to be resting on this portion of my head. It's important for my head to be elevated because if I was flat, I would get congestion in the surgical site. We know that we do not want congestion in the surgical site, especially in the head. It will cause increased intracranial pressure. Supratentorial surgery, the patient is elevated on their back with their head midline or straight. When we look at the positioning for infratentorial surgery, we're looking at someone who is flat in bed and lateral. They are laying on the opposite side of their surgery. If I have received surgery on my right side, I would be positioned flat in bed on my left side, keeping pressure off the incision site, keeping me flat. Elevating the head of my bed would put pressure from the top portions of the skull and brain and could interfere or destroy surgical suture sites and compress portions of the brain itself. When we look at the fourth point, monitoring vital signs and neurological signs, this we're looking for improvement as well as deterioration in the patient's status. We will again institute the Glasgow Coma Scale, and we will be following pupillary changes. Are the pupils still equal, round, reactive to light, and accommodation? As we move forward looking at further implementation associated with intracranial tumors, we come to the use of medications. Corticosteroids are always used in the treatment of intracranial pressure changes. We are trying to decrease cerebral edema, and following surgery, because of tissue damage, we will get swelling around the surgical site. Corticosteroids will decrease this inflammatory response and decrease the intracranial pressure. Osmotic diuretics are used again to decrease the volume of circulating fluids as well as decrease the swelling. Analgesics are used to try and treat the pain. If any of us can imagine going into surgery and having someone cut through the skull bone, there's no question that we're going to have pain. Analgesics are used, and it is usually Tylenol. The fourth medication we're going to discuss on this slide is anticonvulsants. When we go in and do brain-type surgery, we can irritate the brain structure itself, giving rise to seizure activity. Not only is the patient going to be placed on anti-seizure medication or anticonvulsants, we are also going to institute seizure precautions. Now let's look at a couple other medications that are used to treat a patient with intracranial tumors which has had surgery. Antibiotics. Meningitis is a side effect to any time we cut into the closed brain or affect the circulating cerebral spinal fluid. Antibiotics would be used prophylactically to decrease the risks of infection. Antipyretics will be used to control temperature. If we have operated on the thermoregulating center in the brainstem, this patient would be at higher risks of elevated temperatures as well, not just temperature that results because of surgery. Antipyretics and possibly a cooling blanket would be used. Antiemetics are used to cut down on nausea before vomiting occurs. We know that vomiting or even suctioning a patient can cause an increase in intracranial pressure. By using antiemetics prior to the onset of vomiting, we can prevent this increase in intracranial pressure. If we have operated on an organ within the brain that would have produced hormones, it will be necessary for us to go back and provide hormone replacement. The pituitary gland would be an example of such need for hormone replacement. Narcotics are never used. Two reasons that narcotics are not used. One, narcotics sedate and mask the signs and symptoms of restlessness, which would indicate an increased intracranial pressure, as well as narcotics constrict the pupil. When we constrict the pupil, we increase intracranial pressure. Narcotics such as Demerol, morphine, or Dilaudid are not used in a post-op intracranial tumor patient. We're going to move now out of brain-type cancers and move into pancreatic tumors. What do we see that's different with a patient who presents with a pancreatic tumor? Pancreatic tumors frequently present with weight loss, just like any other type of cancer. But these patients have a vague upper or mid-abdominal discomfort that may radiate into their back. It may actually resemble or mimic the pain associated with an ulcer. They are usually hyperglycemic. The pancreas is being stimulated by an unusual tumor mass and actually will cause the insulin production to be decreased, and so hyperglycemia can occur. Jaundice occurs, and this is because the pancreas is part of our biliary system, and we get congestion through the drainage of bile from the gallbladder. So jaundice will occur, as well as clay-colored stool. If the bile cannot get into the GI tract, it cannot be excreted in our stool or color our stool. So as the stool becomes gray in color, the urine takes on a darker or amber color where the bilirubin is being excreted now. Now, as we look at the treatment for pancreatic tumors, we know that the treatment for these patients is usually palliative. Pancreatic cancer carries a very, very high mortality rate. And so when we go in to try and provide treatment, one of the first things we're going to do is try and get them ready for their surgery. Give them high-calorie, bland, low-fat diet. Give them foods they can digest. We don't want to give a high-fat diet. This stimulates the release of bile. And if we have gallbladder problems, we get pain by a high-fat diet. And in this case, because the pancreas is connected with the biliary system, we will get pain also. Bland helps with digestion, decreases nausea and vomiting, and the high calories are needed to try and help with cell repair and weight increase. If they decide to go in and do a surgical procedure, the procedure will be called the Whipple. It is a bypass procedure that hopes to get around the tumor and allow drainage of the biliary system. Again, it is a palliative procedure used to decrease pain and discomfort. Post-op care would be very similar to that of biliary and abdominal surgery. Medications that are used for patients with pancreatic carcinoma include chemotherapeutic agents and anticholinergics. We're going to start with the second one. Anticholinergics are given to the patient in order to decrease the secretions that are produced both in the stomach and the GI tract, thus cutting down on the excretions that are going through our intestinal system. Chemotherapy, again, is used to try and shrink the tumor and eliminate the abnormal cells. Now, what would be some of the complications that might occur as a result of pancreatic carcinoma surgery? Those that we would see with someone with abdominal or biliary surgery. Infection, obstruction of the T-tube, and remember that the T-tube is placed in the biliary duct and allows bile to drain instead of backing up. Oftentimes, pancreatic carcinoma patients go home with a T-tube and small biliary bag in place. Remember, this does not hang down to the floor, but lay next to them. Hypotension could occur. Again, if we are hypovolemic, we will get hypotension. Fatty stools and supplemental pancreatic enzymes might be needed in order to enhance the absorption of the nutrients that we're getting in the diet. If pancreatic enzymes are used, remember they are always administered before the food, not with or after. If the patient continues to have increased blood sugars, it will be important for us to intervene by placing the patient on insulin therapy as we would a diabetic. Now, the last area that we're going to discuss in this unit today is on laryngeal carcinoma. We're going to start first with looking at the assessment of a patient who presents with carcinoma of the larynx. And anybody who watched the movie, this was what John Wayne eventually presented with. He had hoarseness, dysphagia, difficulty swallowing, probably foul breath, but I wasn't close enough to know that, dyspnea, shortness of breath, enlarged lymph nodes, and hemoptysis. Hemoptysis seems to be a key symptom for patients to relay or clients to relay to their physician in trying to help with the diagnosis of laryngeal cancer. Patients that are at risk of developing laryngeal cancer are those that chew tobacco, smoke, especially cigars and pipes, unfiltered cigarette products, and drink a lot of shots of liquor because it's burning to the throat. There is also a familial tendency. Now, if the patient presents with laryngeal carcinoma, we know that the larynx is going to be removed. So what are some of the implications in the care of the patient after they have had a laryngectomy? A laryngectomy requires the patient to be in a semi-Fowler's position. We have cut into the throat. It's a vascular area where bleeding can occur. So by elevating the head of the bed, we help with breathing and allow any secretions to not collect at that site. Stomal care will be started. A laryngectomy patient is going to have that tracheostomy that we talked about earlier in this film series. And we will talk about stomal care and suctioning when we do reduction of risk. Suctioning will occur anytime the patient presents with an obstructed airway, either from secretions, from blood that's accumulating there, or if we were to see their blood oxygenation count dropping on either the pulse ox or their ABG. We need to keep their airway open. Nasogastric feedings will be instituted in order to prevent the patient from having to swallow. Nasogastric feedings would bypass the surgical site but need to be colored with food coloring. We need to make sure that what we are aspirating out of the lung with suctioning is not something that has been aspirated if the patient became nauseous or regurgitated any stomach content. It is usually colored with blue or green, not red food coloring. The patient's also going to be taught how to take care of esophageal speech or the use of an artificial larynx. This teaching takes place once the patient is able to swallow without difficulty. Additional treatments might include also antibiotics and decongestants. Now, when we look at this patient with a laryngectomy, it's important to remember that the patient cannot communicate normally. And until we can set them up with artificial devices to compensate for that, we need to provide them another means to talk. They need to be able to ventilate. They have dealt with a terminal problem or a potentially terminal problem, at least something that has significantly altered their self-esteem and ability to operate in the real world. They need to be involved also with psych counseling if needed, and the family needs involved in their care. The family may in fact be the ones doing the suctioning and stomal care if the patient does not have the manual dexterity to do so. This completes the unit on physiologic adaptation. I thank you for listening to this film and hope that if you have any additional questions, you will reread your textbook. I wish you good luck on your Nclex.